So very good evening everyone. Good evening everyone. Hope I am audible and visually is clear to you. A very good evening everyone. Good evening everyone. I am Dr. Ankit Goel, your psychiatry faculty. Good evening Ganesh. Good evening Dr. Sunshine. Good evening Nani. So a very good evening everyone. We'll be starting today's session. Now, as all of us know, your FMG exam, is there on 20th of January. So we have around 35 days. So today we are going to discuss, important topics of psychiatry. Good evening Rahul. Good evening Ashwin. Good evening Dr. Mohammed. Good evening Abdul. Good evening Mohammed Hassan. Good evening. A very good evening to all the doctors. Hope all of you are doing good. Good evening Ali. Good evening Mitesh. Narendra. Good evening Sebab. Good evening Putin. Right. So I hope all of you are doing good. You're preparing well for the exam, right? So let us start today's session. Now in this today's session, we are going to talk about important topics. We're going to talk about high yield topics or the must know topics. In this session today, I'm going to cover a lot of your previous MCQs. So PYQs will be covered. Also, I'll be discussing, I'll be talking about certain questions which can come as a future question or as an FQ. Okay. And also, as we always do, I'll be going to give you a lot of tricks, which will help you remember a lot of concepts in psychiatry. So let us begin. Good evening, Avinash. Good evening, Rishabh. Right. So let us begin now. Let's start with MSc. So when we examine a patient with psychiatric symptoms, we examine the examination is known as mental status examination or the MSc. Again, it is important. You should know this. This has been asked previously as a MCQ. Now, in the MSc, let us talk about first the mood and affect. Let us talk about the mood and affect. Yes, it will be also helpful for the NEET PG as well. Yes, a lot of questions, come from FMG come to NEET PG and NEET PG come to FMG. So I am going to discuss a lot of such, overlay of questions. Yes, it will be useful, right? Yes, you will be getting the PDF. Don't worry. Let us start. Yes, right. So, let us understand when we say mood and affect, both of these terms are basically related with the emotions, right? So in psychiatry, we try to understand the emotional state of the patient, right? Now, but let us understand what is the difference. Now, mood is a persistent and pervasive emotional state. Persistent means something which is present for which is present most of the time, and pervasive means which is present, most of the places. So a patient says, sir, whether it is morning or evening, I feel sad. Or whether I'm at my office, at my home, or I'm in a kitty party, I feel sad. So this this is the mood of the patient. Mood is something which is persistent and pervasive, and it should be present for a long time. It is present for a long time. So suppose if I have to ask your mood, I will ask you how has been your mood since the past few days or weeks. Okay, so this is mood. Then what is affect? Affect is basically expression of emotion or something which we as a therapist observe. Okay, so I'm talking to a patient, many a times it happens that many of our family members, friends, they've not said anything, but they appear sad, and we go and ask them what happened. So from their facial expressions, from their body language, we can see their affect. So this is the difference between mood and affect. Mood is something which is internal, affect is something which is external, which we observe. Okay, so now since we know the difference, let us talk about some important abnormalities of affect. Again, this is very, very important. Nowadays anything which trends, we put a hashtag. So I'll be giving a lot of hashtag topics. You can expect such questions in the exam. Two important abnormalities in affect I want you to remember. First is flat affect. Okay, what is flat affect? Flat affect means the emotion is not changing. It is also known as sometimes blunt affect. Okay, flat affect or blunt affect. When how is the ECG of a patient who is dead? How is the ECG of a patient who is dead? It's a flat line. Similarly, you can remember like this: flat affect is as if the emotion is not changing. For example, let me give you an example, and similar question can come in your exam. So I'm talking to a patient and I'm talking about some sad event in his life. Let us say 1 year back, his parents died in a car accident. I'm talking about something sad, okay, but the patient looks like this. There is no change in the emotion. Now again, I'm talking about some good incidents in his life, okay, something good has happened. So I'm talking about this, let us say 6 months back he was promoted. he became a father. So I'm talking about some good event, but still the patient is looking like this. This is what is known as flat target. A similar question can be asked in your exam. Okay, so you should know what is flat affect or blunt affect. Can anybody tell me where will you find flat affect? Anyone? कोई मुझे बता सकता है flat affect कहाँ मिलेगा? Anyone? In which condition? Again, this is important. You will find flat affect again. It can be seen in schizophrenia. This is very, very important. Okay, schizophrenia. Schizophrenia is a psychotic. It's a psychotic condition. Okay, okay. It can be seen in schizophrenia. And in depression, में the the affect will be sad. Here I am saying that the emotion is not changing. Okay, as if the emotions are dead, flat. Okay, so this is flat affect. Very, very important. Now, second important abnormality which you should remember is labile affect. Again, you can remember like this. It is like the opposite. Here, what is happening? Without any reason, there is rapid and abrupt changes in emotion. Okay, now without any reason, the emotions are rapidly and abruptly changing. For example, again, similar condition can be asked in the exam. So I am talking to a patient. I have not cracked any joke. Patient has not cracked any joke. Nothing funny has happened around, but patient starts laughing. And within few seconds, the patient starts crying. Then again starts laughing. This is rapid and abrupt changes in emotion. That is labile affect. So देखो, flat affect में the emotions were not changing. Here, without any reason, the emotions are changing. This is labile affect. Again, very, very important. Can anybody tell me where can you find very good? Yes, Putin, Rishabh, Vish, yes, very good. D, Navneet, Dr. Sunshine, very good. It can be seen in two important conditions I want you to remember. One is mania or bipolar disorder, yes. And second I want you to remember is organic mental disorders. Okay. So again, the same example, just like the example we have discussed, similar questions, can be asked, because nowadays a lot of such clinical based questions they ask. Okay. Now, let's talk about the next point under mood and affect. Let's talk about anhedonia. This is again a question, 2019 question. So I will be discussing a lot of the topics which have been recently asked in your exam. So again, this was a direct, question came, in the exam. So what is anhedonia? Anhedonia is decreased interest in previously or in pleasurable activities. So activities which earlier patient would enjoy. So for example, a 30-year-old female says, sir, in the past 2 days, I don't enjoy watching movies. I don't enjoy, going to the kitty parties. Okay, I don't enjoy shopping, which earlier, I used to enjoy. So this is anhedonia. Okay, so they had asked what is anhedonia. So they were given a situation and that was anhedonia. Now, can anybody tell me where will you find anhedonia? Very good. Yes, anhedonia can be, yes, it can be seen in depression. Very good. And it can also be seen even in schizophrenia. Very good. In fact, it is one of the negative symptoms of schizophrenia. Okay, it is one of the negative symptoms. We will discuss about it. Okay, so again, this is important. Now let us try to correlate some neuroanatomical, questions, structures related with emotions. Now there are two important, structures I want you to remember. First is where the emotions are generated. Can anybody tell me where the emotions are generated? Which structure is involved in the generation of emotion? Anyone? It is the limbic system. Very good. It is the yes Navneet, very good. It is the limbic system. Second is I want you to remember. Very good. Yes Vish, Anita, very good. Nazish, very good. Pratibha, very good. Now second is I want you to tell me which area regulates emotion. Again, it is, let me give you a hint. It's a cerebral lobe. It is the largest cerebral lobe. What is that? What is the answer which regulates? Yes, very good. It is the frontal lobe. It is the frontal lobe. Now frontal lobe, again, let me give you, few important other things which may be associated with frontal lobe. Again, such questions have been asked previously, So frontal lobe, one we have learned it regulates emotion. Again, some important points. If frontal lobe is affected, what all things can get? So let me give you, a list of certain symptoms which you can get. This is again very important. You can find disinhibitory behaviors. So if frontal lobe is affected, if frontal lobe is damaged, you can get, symptoms like disinhibitory behavior. What is disinhibitory behavior? Now, there are certain behaviors which we inhibit ourselves from doing. For example, Suppose you're in the class and you get a urge, there's a nature's call. So you'll wait or you'll go to the washroom to empty the bladder. Okay, so we know certain inhibitions. But if frontal lobe is affected, these inhibitions may be lost. So in fact, there was a there was a previous AIMS question. A person goes out in public and starts micturating and does not have any guilt for the same. Which lobe may be affected? It is a disinhibitory behavior. That is, answer was frontal lobe. Okay. Also, if frontal lobe is damaged, again, you can also get personality changes. Okay, personality changes may also be seen. Okay, basically personality, we'll talk about it when we'll talk about personality disorders. Personality is basically, a day-to-day, certain behaviors with which we deal with day-to-day situations. So all of us have, our personality. So when frontal lobe is affected, we say personality also changes. Okay, so this is a list of, some important symptoms which you can get when frontal lobe is affected. Again, this is important. Okay, right. Let's talk about the second important topic in the MSc, very, very important topic, one of the most important. A lot of questions in the past have been asked from this. Okay, yes, it can be, personality changes, yes, it can be aggressive behavior, yes, very good. Now, thought again we divide into 4 domains. So, abnormality of thought we can divide into 4, that is flow or stream, that means the thoughts are flowing. So, normally, our thoughts flow. Sometimes there is abnormality of the flow of thought. Second is content. Okay, so there may be abnormality in the content. Whatever the person is thinking, there can be problem in the content. Okay. Then third is form. Okay, form basically means structure. Anything around you, has a structure or form. Similarly, our thoughts also have a form. When that form is abnormal, we say there is abnormality of form or formal thought disorder. And lastly is possession. Okay. Normally, all of us know, any thought which comes to your mind, whose thought is this? Which comes to your mind, we say it is your own thought. I possess my thought, but sometimes it may not be there. Okay, so there is abnormality of possession. Okay, so I'm going to discuss some important, since we are revising, I'm going to discuss some important abnormalities under each of them. Okay, let's talk about the first abnormality, which is the flow or stream. Okay, right. So let us discuss first. So first, under the flow of stream is flight of ideas. I always say, psychiatry becomes very easy if you remember, the terms from, the concept from the names. Okay, flight of ideas means the ideas are on a flight. That means the thoughts are moving very, very fast. Okay, so thoughts follow each other rapidly, and we say the goal is not reached. Okay, goal is not reached means if I ask a patient who is having flight of ideas a question, the patient may say so many things, one thing, second, third, fourth, but he may not answer my question. So the goal is not reached. Okay, one important point in flight of ideas I want you to remember is patient will be speaking a lot in flight of ideas because the thoughts are rushing in his mind. But still, although they are illogical, but these thoughts are connected somehow. This is important, especially for your exams. There is some connection. This connection can either be by chance. Okay, it can be a by chance, random. By just some chance the thoughts are connected. For example, let me give an example. A patient may speak like this: my name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. So, again, everything which he is saying, again, does not make sense, but they're connected by some chance factor. ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही धुन, something like this. Okay, so this is by chance, and sometimes they are also connected by clang association. Thank you, Ankit. Thank you. So they are connected by some clang association, means some rhyming words. So patient may speak like this, Ramkin sings, birds have wings, I am the king, the phone goes tring tring, the weather is spring, bring pring pring bring bring. Something like that. Again, nothing is making sense, but it is still connected by some rhyming words. So this is again very good. Yes, Nani. Illi, jali, idli, something like this. Very good. Okay, so this is flight of ideas. You should know, please understand, such questions are being asked in your exams. I'll show you one question. So can anybody tell me where you will find flight of ideas? One important condition I want you to remember for flight of ideas is it is seen in mania. Okay, we'll talk about mania. Patient has, excessive energy, patient's mood is elated, and there is flight of ideas also seen. Okay, so let us, talk about, if you see this question, this was a previous, FMG question. Patient says, you know, home is sweet, sweet in diabetes, diabetes urine has smell, smell is hell. If you see, again patient is speaking many things which is not making any sense, but if you see, are they connected somehow? Yes, they are connected somehow. So the answer for this was very good, B, flight of ideas. So such questions have been asked in your exam, okay. So try to understand the concept. Second is, this is again an important, you know, topic which you can expect as a FQ. You know, this question can come as a FQ. This is again very, very important. Thank you, Abhishek. This can come as a FQ. Very, very important, perseveration. So this can be a new question for your exam. What is perseveration? Again, try to remember, you know, what is the meaning of perseveration in English? Something, you know, to repeat something. Okay. So you can remember it like this, 3 P's. P for perseveration, P for persist. A thought is persisting. Thought persists beyond the point of relevance. So 3 P's are there. Perseveration means a thought is persisting beyond the point of relevance. मतलब एक thought is, you know, repeating again and again, although उसकी relevance खत्म हो गई. This is perseveration. How you can be asked this question? You know, so you know, suppose you ask a patient, what is your name? The patient says, my name is Mukesh. Okay, the patient says, my name is Mukesh. Then you ask the patient, what do you do? The patient says, my name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. So what is happening? Initially this thought that my name is Mukesh was correct, but now it is persisting beyond the point of relevance. Now it is not relevant anymore. Similar question can be asked in your exam. Okay. So again, this is perseveration. You should know the concept. ठीक है. Okay, I'll repeat things in Hindi also, but don't worry, that will be also be repeated in English. ठीक है. So ये है perseveration. This is perseveration, right? So can anybody tell me where will you find perseveration? 2 important conditions. 2 conditions हैं जो आपको पता होनी चाहिए. First is, पहला कौन सा condition है? It is organic mental disorder. Organic mental disorder. Okay. Organic mental disorder. And the second is very good, schizophrenia. Very good, schizophrenia. Okay, so this is again an important concept. Again, you can get such question. Okay, so I have tried to tell. So they may say a psychiatry resident is interviewing a patient and patient is repeating few things again and again. What is this? This is perseveration. Clear to everyone? Right. Now, next is content. So now we have discussed some important, you know, abnormalities of flow. Again, we are going to discuss content. Okay, in content there is one important abnormality which I want you to remember, that is delusion. Okay, delusion. What is delusion? It's a false, fixed, unshakable idea or belief. So patient, you know, starts believing something which is not true, but he is fixed. He does not, you know, his belief is unshakable. आप उसको change नहीं कर सकते belief को, because he is holding it with extraordinary conviction. Patient is totally convinced that what I am thinking is right. This is what is a delusion. So delusion is false belief. Very good. ये एक false belief है. ये patient की thinking में है. Okay, this is in the thinking. Okay, for example, you know, patient says that the neighbor wants to kill me. Wants to kill me. Is totally, you know, totally convinced that the neighbor wants to kill me. Okay, I'll talk about organic mental disorders. Don't worry. Okay. Yes. Yes. These are the 2 important points. Yes, it should not be in sync with his, you know, social, cultural, emotional, you know, and educational background. Okay, that means he is only the person who is holding that, you know, this belief. Other people are not believing him. Okay, so this is delusion. So what is this example? Can anybody tell me? Neighbor wants to kill me. He is totally convinced, you know, although this is not true. Everyone is trying to convince him. So this is how you will be given, you know, that you have to understand that this is a delusion. People are trying to convince him otherwise, but वो convince नहीं हो रहा. So that is a delusion. So this example is delusion of persecution. This is delusion of persecution. Very good. Okay, so there are various delusions. Okay, then there is delusion of reference. Okay, delusion of reference is when the patient says that the people are talking about me. People are talking about me. Okay, he is convinced, or someone is spying on me. Okay, spying on me. So these are some of the, you know, delusions. Okay, so you should know the concept of delusion. Some important, and again, you know, questions which can come, you know, in. So this question again, you know, let us take this question. This is again a simple question, was asked in 2019. Delusion is a disorder of which of the following? What is the answer? What is the right answer? So such simple question: thought, affect, perception, or memory. It is a disorder of. It is a disorder of. Can anybody tell me? So simple, it is a disorder of thought, and under thought, now you know it is a disorder of content of thought. So next time they may ask you flow, content, form or possession, it is a disorder of content. Okay, such questions come in the exam, even in your NEET PG also, such simple questions do come. So please try to remember these. Okay, now let's talk about some important, questions which can come. First is, you should know, again, it's a type of delusion, Othello's syndrome, also known as delusion of infidelity. What is the meaning of infidelity? It is also known as morbid jealousy. It is also known as morbid jealousy. So basically, infidelity means that the partner, the partner is having an affair, okay, or is cheating. So here, in delusion of infidelity, patient believes that the partner or spouse is having an affair. Although this is not true, but the person is convinced. Okay, person is convinced. Now please remember, delusion is it's a psychotic symptom. Okay, we'll talk about this. It is a psychotic symptom. Okay, it's a psychotic symptom. Okay, so it is seen in disorders like schizophrenia, delusional disorder. It's a psychotic symptom. Okay, so it can be seen, so it's a delusion, it can be seen in various psychotic disorders. One important substance I want you to remember, the reason for this explanation is I want you to remember one important substance which if the patient consumes. Okay, so a patient is consuming a substance and he starts believing that my, let us say, wife is having an affair. So the question may come, which of the following substance the person may be consuming. Person is consuming, kaun sa substance consume karne se the patient may develop this delusion? Can anybody tell me? Very good D. Yes, it is alcohol. Very good Bhaskar, it is alcohol. Again, this is very important, please remember this, such questions may come. Okay, now next is, again in delusion, there is something known as delusional misidentification syndrome. Two important syndromes I am going to discuss. So as the name suggests, misidentification. Patient is having difficulty in identifying the other person. So there is misidentification. Okay, two important syndrome under this I want you to remember. First is Capgras syndrome. Yes, very good. So what is Capgras syndrome? Patient believes that a close person, someone who is closely related to me, has been replaced by an exact double. This is the patient's belief. So let us say a husband, husband is admitted in the hospital and his wife comes and comes to meet him. We know that she is the wife, but the patient says that you're not my wife, you are a hospital nurse. Let us say he says that you're not my wife, you are a hospital nurse. So what has happened? Patient believes that someone closely related to him, who is closely, the wife is closely related to him in this question, has been replaced by an exact double. So he says that I know you look like my wife. So physical appearance, he acknowledges that it is the same, but he says that you are not my wife. So this is misidentification. Okay, this is Capgras syndrome. Again, a similar question has been asked in AIIMS also, and even in the FMG exam in 2018 this question was asked. So many times you have confusion. Let me give you a trick to remember. From the name itself you will remember. Exactly the same question was asked in your exam. Capgras syndrome is. This was a question. So just remember, see the name and remember from the name. Okay, remember from the name. The name is telling you what is Capgras syndrome. So just see, close person replaced by stranger. Just see, the name is telling you the answer. Is it clear to everyone? So remember such tricks. Okay, so remember such tricks and it will be very easy for you to remember. Okay, is it clear to everyone? Right. So again, one trick you can remember that here, here the person is arguing with whom? He is fighting with, he is arguing with whom? So C for Capgras, he is arguing with the close person. Like in this case, he is arguing with the wife. So is it clear? I have given you all the tricks to remember. Okay, अभी नाम से ही आप याद कर सकते हो. Is it clear? Next is Reguli syndrome. Okay, here it is the opposite. Here the person believes that a familiar person or a close person is imposing as a stranger. अभी वो believe कर रहा है कि मेरा familiar person, close person is imposing as a stranger, and sometimes he believes also that he can take multiple appearances. This is Reguli syndrome. अभी उल्टा है. For example, a patient, let us say Mr. Freg, okay, he is walking, he is the patient, he is walking and he meets a stranger S1. ये stranger है, he is a stranger, let us call him S1. He says to this stranger, I know you look like a stranger, but you are not a stranger. You are my wife. Okay, you are my wife. Okay, so we know the person, this S1 is a stranger, but patient को क्या लग रहा है? That his wife is coming in front of him as a stranger. So this is Reguli syndrome. This is the opposite. Okay, is it clear? ये opposite है. Okay, thank you everyone. So this is the opposite. Is it clear to everyone again? So you can remember here the patient is fighting, arguing with close person or with stranger. Tell me. Okay, tell me, close person or stranger. Can anybody tell me? यहाँ पे किससे fight कर रहा है patient? Patient is fighting with the stranger, Okay, is it clear? So please remember, these questions have been directly asked in your exam. They have simply asked, and you know, now they can also ask as clinical question. Very good, Rameshwar, Rishabh, Mansi, very good, thank you. Now, so we have discussed the contents. Next is form. देखो, form का मतलब होता है organization. जो भी हमारे thoughts हैं, all our thoughts, you know, they have a structure. Okay, every thoughts, you know, they will have a start, middle part, and it will have a end. हमारे जो भी thoughts होंगे उनका एक beginning होगा, एक middle part होगा और एक end होगा. Okay, when there is abnormality of form, हम उसे कहते हैं formal thought disorder. देखो, formal is derived from form. Okay, इसे हम FTD भी कहते हैं कभी कभी, formal thought disorder. Formal thought disorder का मतलब क्या है? That there is disorganization. And again, please remember, it can be seen in schizophrenia. It is, in fact, it is one of the symptoms of schizophrenia. Now, there was a very interesting question asked from this topic in your FMG exam. Okay, let me talk about some important abnormalities of form. First is loosening of association. देखो, if even you don't remember, just see the name, loosening of association. What does this mean? That means जो association है thoughts के बीच में, the association between the thoughts, that has loosened up. अब वो loosened up हो गया, मतलब patient, you know, patient is speaking things. Okay, so there is a breakdown, there is a break in the logical connection. There is a break in the logical connection of the thoughts. Okay, normal जो thought है, let us say if you want to have a cup of coffee with your friends, so आपका thought होगा, I'll, you know, take a cab, I'll reach cafe, you know, I order coffee, I'll drink, I'll pay and I'll come back. So एक start है, middle part है, end है, ये normal thought है. Suppose किसी का loosening of association है, अब उससे आप पूछो what will you do? Suppose you want to go on a date, आप coffee पीने जाना है, तो what will you do? The patient may say, I will pay, I will drink coffee, I will come back, I will, you know, I will book a cab. So patient is speaking like this. So the thoughts which were earlier logically connected, now they are not logically connected. So logical connection खत्म हो गया. मतलब words will make sense to you, but sentences will not. You will say, sir, कुछ समझ में नहीं आ रहा, sentences का क्या मतलब है? This is loosening of association. Okay, so very good. Now next is very good. There will be a hodgepodge. Very good. Now next is derailment. देखो नाम से ही पता चल रहा है derailment. Derailment का मतलब क्या है? Initially वो track पे था and अभी वो derail हो गया. So it is basically jumping off the track. Patient is talking, so patient may say like this, I will book a cab, I will reach cafe. Okay, but rather than going to the topic, he now starts saying, oh, today was, you know, India Bangladesh test match, you know, second day, you know, India played very well, so I think we can win the, and he continues that topic. So this is derailment. मतलब उसने, he was on track, now he has jumped off the track, jump off the track to a new topic. This is derailment. What is tangentiality? What is tangentiality? So again you can remember tangentiality को कैसे याद रखो? By the word tangent. Okay, tangent basically is a line which touches the circle at one point and goes away and it never returns. मतलब goal कभी reach नहीं होता. Patient बस topic touch करता है, the patient touches the topic and he goes away. For example, again I ask the same question, what will you do if you want to have a cup of coffee? The patient may say, you know, there is a new cafe, you know, near my house. and just next to you there is a cinema hall, and you know I'm planning to go and see this new movie, you know, which has been released. Okay, and I have heard very good reviews about this movie Drishyam 2, and I'm planning to watch it. So देखो, patient ने वो topic touch किया and then patient has went away, but he has never returned and never answered the question. ये tangentiality. आपके एग्जाम में जो क्वेश्चन आया था, आपके जो, yes, very good. So आपके एग्जाम में जो क्वेश्चन आया था, यू आस्क अ पेशेंट व्हाट इज योर मूड, हाउ इज योर मूड, द पेशेंट सेज सर माय मूड इज अप एंड डाउन. देखो ये थोड़ा ट्रिकी क्वेश्चन था, इट मे नॉट बी अ कंप्लीट क्वेश्चन, बट अगर आपको आंसर लगाना है, द पेशेंट जस्ट रिप्लाइड इट इज अप एंड डाउन. ओके, अभी अप एंड डाउन यू डोंट नो, यू नो, सो अभी क्या आंसर होगा, विल इट बी डिरेलमेंट और टेंजेंशियलिटी? कैन एनीबडी टेल मी? ओके, यू कैन वॉच एवेटार 2 ऑल्सो, येस. ओके, सो क्या होगा, it will be derailment or tangentiality. Some of the books have given it wrongly. So please understand, for derailment we should know that the patient is on track. तभी तो वो derail हुआ. Here he just said up and down. So maybe he just touched the topic. We don't know where he is heading. But from the question it seems that it is tangentiality. So ये आपका again FMG question है. Please, such question, if you can see, such question have been asked. Okay. Next is neologism. Again neologism is very simple. Neo का मतलब होता है new, and logism means word. So patient, you know, out of nowhere patient derives a new word जिसका कोई meaning नहीं है उसकी language में. Okay, in his language, the language which he knows, this word is nowhere. So he suddenly derived a new word. For example, patient may say, sir, I bought a new PrepLadder. Okay, and you don't know, he just knows English and he says, I've brought a new PrepLadder. What is this? You don't know, and then he points to his wristwatch. So he derived a new word whose meaning you cannot understand how he derived. ये है neologism. Okay, again, yes, tin tin tapa, yes, something like this, very good, yes Manchi. Okay, Nazib, yes, good, very good. So is it clear? Again, such, you know, such clinical based questions have been asked. Okay, so please remember this. अभी NEET PG में क्वेश्चन आया था, which of the following is a disorder of form, उसमें एक ऑप्शन था derailment. So you know derailment is a disorder of form. Okay, such question can also come, very good. Lastly, it is possession. Last is possession. Now in possession, two important entities come. One is obsession. You can remember, obsession rhymes with possession. Okay, so again it rhymes. So again in certain books obsession is placed under content. Okay, in certain books, so you can remember obsession is a disorder of possession. I'll talk about obsession in detail when I'll talk about OCD. Okay, obsession basically patient is having repeated thoughts which person is not able to control. Okay, he is not able to resist these thoughts. ये है obsession. We'll talk about it when we'll talk about OCD. Okay, very good. We'll talk about it in OCD. Next is in possession is thought alienation. So from the name itself you can see alienation. My thoughts are, you know, alien. My thoughts are under some outside influence. मेरे thoughts बाहरी influence में. You know, someone is influencing my thoughts. There are three entities in this. Yes, very good. Obsession हम discuss करेंगे in OCD. One is thought insertion. As the name suggests, patient says, sir, someone is inserting thoughts in my mind. There is a thought in my mind that I should go and have a piece of cake. But sir, this thought is not my thought. Someone has inserted this thought in my mind. ये क्या हो गया? Thought insertion. Next is thought withdrawal. Thought withdrawal क्या है? Patient says someone is withdrawing thoughts from my mind. Someone is withdrawing. Sir, there was a thought in my mind, but right now I don't know where it went away. Someone has taken away my thought. ये क्या हो गया? Thought withdrawal. Very good. Somebody took my thought. And thought broadcast, you know, just like, you know, when you watch, let us say अभी match हो रहा है बांग्लादेश में, but you can watch in your television sets. Okay, so basically it is getting broadcasted. Thought broadcast, patient says everybody is able to know my thoughts. My thoughts are getting broadcasted outside. Okay, I enter a room full of people. वहाँ पे सब लोगों को मेरे thoughts पता चल रहे हैं because my thoughts are getting broadcasted. ये है thought broadcast. Okay, so please remember, these are under thought alienation. Again, these can be seen in disorders like schizophrenia. Okay, these can be seen in disorders like schizophrenia. Right? Clear to everyone? Again, this is important. Right? Now, next under the heading of MSc, next is perception. Okay, next is perception. देखो perception basically क्या है? Anything, you know, through our sensory organs, anything which we perceive, you know, we can hear things, see things, taste, smell or touch. This is sensation. Okay, this is sensation. When there is abnormality in sensation, we say it is disorder of perception. Two important entities, you know, yes, very good. Two important entities here. One is illusion. Okay, what is illusion? illusion basically is a false perception. Again, it's a abnormality of perception. तो ये false perception है, but of a real object. कोई real object है, उसकी false perception the patient is experiencing. For example, very commonly, you know, person is sleeping in the night and wakes up and says that he can see a snake under his bed. उसको अपने बेड के नीचे एक स्नेक दिख रहा है. He is able to see. देखो ये perception है. He can see the snake. Okay. Then he switches on the light. Family members आते हैं. He shouts. Family members आते हैं. They switch on the light, and he actually sees that, oh, it was actually the rope. So this snake is a false perception of the real object. Real object क्या है यहाँ पे? Rope. So illusion, all of you must have also experienced. So it can be seen even in, you know, normally people, you know, can experience illusion. ये है illusion. Okay. Yes. Next is hallucination. Next is hallucination. Now what is hallucination? This is again important. Again it is a psychotic symptom. What is hallucination? Again it is a disorder of perception. So ये भी एक false perception है, but without any real object. There is no real object. So patient says that he can see a snake under his bed. You know, even, you know, you switch on the light, he is still able to see the snake. No one else is able to see the snake. किसी और को snake नहीं दिख रहा और वहाँ पे कोई और object भी नहीं है. It is the patient is just seeing the snake, nobody else, and you can see very clearly as a real object. So this is hallucination. Have you seen the movie Lage Raho Munna Bhai? Have you seen the movie Lage Raho Munna Bhai? Anyone? In which the hero is able to see Mahatma Gandhi, is able to hear Mahatma Gandhi. We know, all of us know that Mahatma Gandhi is no more with us, but the hero is able to see and, you know, clearly hear him. That is a classical example of, yes, it is as real and vivid, classical example of a hallucination. Okay. Now hallucination, you know, again can be of various types. Okay, types of hallucination. Few important points about each I want you to remember. Again, very important. Yes, very good. Now first is auditory hallucination. Auditory का मतलब क्या है? He is able, you know, patient is hearing something which is not true, but patient को, you know, he is able to hear. Please remember, it is the most common hallucination. Out of all the hallucination in psychiatric disorder, we say auditory is the most common. ठीक है. Second is visual hallucination. Visual is the patient is able to see something. Again, it can be any object, like in the case, you know, it can be any object like a bottle. It can be animal or it can be humans. Patient is seeing, you know, something which is not there. Now in visual hallucination, I want you to remember, देखो, hallucination एक psychotic symptom है. We learn that it can be seen in disorders like schizophrenia. But visual hallucination, when you see in the question or even if आप clinically अगर ये देखते हो, which important entity, कौन सा diagnosis should come to your mind? Try to see. Yes, very good. Organic mental disorders. Very good. Organic mental disorders. This is very, very important. Okay. Of course, it can also be seen in schizophrenia, but this is important. Visual hallucinations may be commonly seen in organic mental disorder. ये बड़ा important. I will talk about organic mental disorder in a while. ठीक है. Now next is olfactory. Olfactory means patient is smelling something although there is nothing around. किसी को कोई smell नहीं आ रही, but patient को smell आ रही है. Okay. And then there is gustatory. Gustatory का मतलब है taste. There is nothing kept on the tongue of the patient, but patient को कोई taste आ रहा है. Now, important point about gustatory and olfactory hallucination. देखो, temporal lobe disorders जो हैं उनमें, you know, in temporal lobe disorders we can find, you know, we can find all of these hallucination. But very importantly, you know, many a times in temporal lobe disorders you will find these olfactory and gustatory hallucinations. Temporal lobe epilepsy or temporal lobe disorders. Okay. So this is, you know, point you can remember. Okay. And lastly, there is tactile hallucination. Tactile hallucination. Tactile का मतलब क्या हो गया? What is tactile? Touch. Okay. Tactile hallucination. There is a sensation of touch. Okay. So patient says that, you know, there are some insect, he can experience some insects crawling under the skin. So this is also known as formication. Okay. The patient experienced some insects crawling under the skin. Although of course there are no insect, but patient को experience हो रहे हैं, वो sense of touch patient को experience हो रहा है. This is formication. This is also known as cocaine bugs or magnum bugs. This is again important. Many a time this question has been repeated. Okay, cocaine bugs. So again, you know, again there was a question, a patient is, consuming a substance and there are scratch marks. Which substance the patient is consuming. Okay, so scratch marks may be because of these tactile hallucinations. Okay, so there were scratch marks. So again this question, a similar question was asked. Okay, very good. Okay, so this is again very important. Okay, we'll talk about again cocaine when we'll talk about substance. So this is hallucination. Again, these are some important points. Now next in the MSc is judgment. Basically judgment is the ability to take right decisions. Okay, based on the information you take decision. In day to day life we take decisions. Okay, so like you got up in the morning, you must have thought I can watch my favorite series in Netflix, I can go and have a cup of coffee. Then you must have thought, oh, my exams are approaching, I should study. So you started studying. So this is judgment. Okay, so judgment is the ability to take the right decisions. Okay, so there are various types of judgment. One type of judgment I want you to remember is what is known as test judgment. Okay, in test judgment basically what we do is we give some hypothetical question to the patient and ask the patient ki wo kya karenge. For example, very commonly, and this is asked in your exams as well, fire problem. Suppose I ask you all, what will you do if the neighbor's house catches fire? Agar neighbor ke house ko aag lag gayi to aap kya karoge? Okay, what will you do? Anyone? What will you do if the neighbor's house catches fire? So I am giving a hypothetical situation and asking you what you will do. Okay, so this question was asked in the exam. A resident is asking a patient what will he do if the neighbor's house catches fire. What is he checking? He is checking test judgment. Okay, of course you'll try to extinguish the fire, you'll try to call the fire brigade, So one patient said, sir, what I will do? I'll pour kerosene. So this is impaired judgment, impaired judgment. Okay, very good. Yes, Rishabh, yes, impaired judgment. Okay, yes, you will try to escape, yes, you will protect yourself. So impaired judgment is basically seen in psychosis. Okay, yes, okay, it's seen in psychosis. Okay, and the last point under the MSc which we are discussing is insight. Insight का क्या मतलब होता है? Can anybody tell me what is insight? Insight is awareness of the illness. Okay, देखो, normally in medicine surgery you may not check insight, but in psychiatry we check, because many a times we see that patient may not know. Patient is not aware that I am having illness. In fact, patient says, sir, I think my family members have gone mad, I am all right, you treat them. But it is the patient actually jisko problem hai. So insight. Okay, insight again we say in neurosis, insight is present. In psychosis we say insight is absent. Okay, so again these are some important headings. Okay, is it clear to everyone? Right. Now there are again two classifications in psychiatry which we will be talking about, many a times we will use. So basically there are two classifications which tell us that what are the symptoms or what is the duration to make a diagnosis. Okay, so there are two classifications. Earlier it was ICD-10 which has been replaced by now ICD-11. Okay, ICD-11 is given by World Health Organization. Okay, and then there is another classificatory system, DSM-5. DSM-5 is basically Diagnostic and Statistical Manual of Mental Disorders. 5 का मतलब है 5th edition. ये APA ने दिया. It is given by American Psychiatric Association. So two terms you should know, ICD-11 and DSM-5. Okay, right. Now there is another older classification. एक older classification भी है. Okay, again this is not very commonly followed classification, but you should know. So earlier we used to classify disorders as organic disorders. Psychiatric disorders को हम organic बोलते थे और functional बोलते थे. Organic and functional. Organic we used to say in disorders which have a apparent visible cause. There is a apparent visible या demonstrable cause है कोई, visible cause. ठीक है. For example, let us say किसी को head injury हो गया. Someone after head injury develop some psychiatric symptoms, so you can see the injury, or you can do a brain scan and you can see the injury. Someone has developed infections. Okay, so someone has developed encephalitis, so you can do TLC, you can do CSF count and you can see the infection. Or suppose someone has low sodium, develop some psychiatric symptoms, so you can check the level. So there is a apparent visible cause is there. Okay, so those were called as organic disorders. And then there was functional. In functional we used to say there is no visible cause. Of course now we know that there is nothing functional, everything has a cause. Dekho, in depression patient, if I do an MRI, I may not see any abnormality, or if I do a TLC count, it may come out to be normal. But now we know that there are certain, you know, abnormalities like at the level of neurotransmitter or genetic factors are there. So there are abnormalities, but earlier it used to be believed that these don't have a demonstrable or a visible cause. तो इनको हम functional कह देते थे. Again, functional was further divided into neurosis and psychosis. Okay, so neurosis and psychosis में divide होता था. Few points you can remember in neurosis. We have learned insight is present or absent in neurosis. Can anybody tell me? Neurosis में insight present है या absent है? It is, yes, it is present, and in psychosis insight is absent. Okay. Again, you know, delusions, hallucinations, these will be present in neurosis or absent in neurosis. Can anybody tell me? ये present है या absent है? They are absent in neurosis, present in psychosis. Now there are many other differences. These are, you know, some differences you can learn. So neurotic disorders में, you know, like anxiety disorders हो गए, OCD disorders, OCD, okay, somatoform. So these are neurotic illnesses. Psychosis में like schizophrenia, okay, acute psychosis we'll talk about. So abhi, you know, what we'll do is we'll talk about the individual disorders. We'll talk about organic disorders. Briefly, we'll talk about psychotic disorders, and then we'll talk about neurotic disorders. This is how we are going to approach. Okay, this is how we are going to approach. Let's talk about organic mental disorders. ठीक है, अभी हम आते हैं organic mental disorders पे. There is a new term to organic mental disorders. Okay, अभी DSM में और ICD में दोनों में organic mental disorders को एक new term दिया है, that is neurocognitive disorder. Okay, this is a new term. Both in both the newer classification. So neuro means something is abnormal in the brain, cognitive, some cognitive impairment is there. So neurocognitive disorder. Three important disorders come under this. Okay, three important disorders come under this. One is delirium, then is dementia and amnestic disorder. Let's try to understand, you know, let's try to understand these. देखो delirium, again I'll tell you what kind of questions are asked in delirium. Again clinical presentation पे a lot of questions have been asked. So delirium में क्या abnormal, what is abnormal? There is impairment of consciousness. So there is impairment of consciousness. Okay, so consciousness impair. What is consciousness? Consciousness is basically awareness of the self and surroundings. Okay. So consciousness is awareness of the self and surroundings. So if it is impaired, okay, we say the consciousness is impaired. Okay. Now, how will they ask you or how will they tell you that patient ki consciousness impaired hai? So few points or, you know, terms they may use in the question. For example, they may use, very good, yes, they may use the term clouding of consciousness. Clouding of consciousness. Okay. In the clear sky of consciousness, now there are clouds. So they may use this term clouding of consciousness. Or they may tell you that the patient is appearing confused. There is confusion present. Okay, yes, there may be disorientation, yet there is confusion. Okay, or there is altered sensorium. Altered sensorium. Okay. Yes, these patients may also appear, you know, there is disorientation. Okay, there is disorientation to time, place and person. They may not be able to tell you the time, the place or the person. Okay, वो hospital में admit है, but they are saying कि they are at their home. That means they are disoriented to place. Okay, so there is impairment of consciousness. There may be disorientation seen, and yes, there is impairment of cognition as well. Okay, cognition भी impaired होती है. Cognition basically has many functions. Okay, it has many functions under this. Okay, many. So there is impairment of memory may be there. Okay. Impairment of language may be there. Okay. Then there may be perceptual motor abnormality. Okay. Perceptual motor abnormality may be there. Okay. That means perceptual motor, you know, just systems of coordination, and that is lost. So we'll talk about cognitive impairment in dementia. ठीक है. So delirium में please remember कि consciousness भी impaired है और cognition भी impaired है. Okay. And very important. So you know, again for delirium, try to look at this. जब भी आप delirium देखो, try to look for, you know, in your question impairment of consciousness. Okay, अगर impairment of consciousness होगा, then only will think of delirium. Okay, because cognitive impairment can also occur in dementia. Okay, so this is again very important. So generally delirium पे जो question आते हैं वो ये आते हैं, like, you know, delirium again it is a acute onset, sudden onset होता है, acute onset of symptoms, acute onset. Okay, and the patient is having impairment of consciousness. Okay, many a times, you know, there are certain stressors or precipitating factors may be there with delirium. Okay, so you can remember, like, you know, patient had underwent some surgical procedure, or he is in the post operative care, patient को fracture femur हो गया, okay, or let us say patient had appendectomy, okay, or patient had a roadside accident, after which he developed some symptoms. Okay, this is again classically, or patient को कोई medical illness है, like there is some chronic illness, okay, there is some chronic illness, there is pneumonia or some chronic illness may be there. Okay, and again it can also be seen with alcohol withdrawal. We'll talk about this, alcohol withdrawal. Okay. Okay, so these are some important risk factors which may be given, precipitating factors may be given in the question. This is again important. Very good. So delirium कब होगा? जब acute onset होगा, and again the symptoms would include impairment of consciousness. This is again very important. Previously a question was asked on this. Is it clear to everyone how to, you know, how to identify delirium? Very important. Now let's talk about, you know, dementia. Now again in dementia there is impairment of cognition. Impairment of cognition. Okay, so cognition is impaired, consciousness is intact. Okay, like there is amnesia. So memory impairment होगा तो क्या होगा? There is amnesia. Patient has amnesia. Okay, then language impairment may be there. Language impairment may be there. So there is aphasia. Patient को aphasia है. Okay, then, you know, perceptual motor जब coordination, you know, that gets, you know, affected. Okay, then patient may, you know, have symptoms of apraxia. What is apraxia? Can anybody tell me apraxia क्या होता है? Apraxia means loss of fine movement. Apraxia, praxia मतलब movement, apraxia. So complaint क्या होगी? Patient is not able to comb his hair, not able to button unbutton his clothes, not able to tie untie shoelaces. Okay, so these complaint. Then there may be agnosia. Okay, there may be agnosia. Okay, these symptoms may be there. Okay, and other cognitive, these are some important cognitive abnormalities which may be seen in the patient. Okay, agnosia matlab is not able to identify, you know, object or faces. Okay, is not able to identify object or, you know, faces. Okay, so these, yes, very good. So these, some of these cognitive impairments may be there, but consciousness is intact. देखो, please understand, delirium में consciousness, cognition both are impaired. Dementia में only cognition is impaired, and amnestic disorder में even out of cognition में only memory impairment is there. Memory impairment is there. Okay, and in memory, in fact, immediate and recent memory, sorry, you can remember, in this recent and remote memory is impaired. Okay, so इसमें भी सिर्फ memory में, that too recent and remote memory are affected. Okay, so this is, you know, you can remember it like this, it becomes very easy. Okay, very good. Now, and one important example of amnestic disorder I want you to remember, we'll discuss it, is Korsakoff syndrome. Okay, is Korsakoff syndrome or Korsakoff psychosis. Okay, we'll talk about this in alcohol. Okay, both antero and retrograde are seen in Korsakoff. Anterograde is more than retrograde. Okay, Mohammed, right. So this is again, you can remember like this. Okay, so this is again very important. Okay, questions may be asked. Now let's talk about the types. Now again, in the types of dementias, again, you know, generally we say dementia, again these questions have been asked in your exam. So let me talk about some important points. So generally dementia जो होता है we say, okay, we say yes, recent and remote, Nazish, yes. So we say generally dementia is progressive, but 15% are reversible. Okay, and some of the reversible causes I want you to remember. One is vitamin B12. So one of the few causes I want you to remember. One is vitamin B12 deficiency. Okay, this is again important, vitamin B12 deficiency. Okay, then even, you know, certain other causes. Okay, certain other causes may be there, like, you know, neurosurgical causes may be there. Neurosurgical causes, you know, patient had a tumor or a brain abscess. Okay, so if you treat it, it will be reversed. Okay, so there can be, you know, certain infections can be there. Infections, very good, you know. So vitamin B12 deficiency is one important. This is asked, this has been asked in your exam. Another important, you know, a lot of endocrinal abnormalities can also present as reversible causes of dementia. One again important FQ which can come, one important is hypothyroidism. Hypothyroidism, this is again very important. Okay, hypothyroidism. This is again important point I want you to remember. Is it clear to everyone? Again, this is important. Hypothyroidism, right? Yes, again, of course, others may be there, but this is again important. Hypothyroidism, right? Now, let's talk about the treatment. Let's talk about the treatment. Okay. Now, in the treatment, now, you know, in the assessment, there is a tool known as MMSE. Okay. MMSE. Yes, there are other deficiencies also, but vitamin B12 is one very important deficiency. Okay. MMSE is basically mini mental status examination. MMSE. Basically, it is done to check the cognitive impairment. So, basically, there is a total score of 30. Anyone having less than 24, we say, is suggestive of dementia. Is suggestive of dementia. Is it clear? Okay. So, now coming to the treatment, again, you know, I always say try to correlate the etiology with the treatment. Okay. Let's talk about, you know, the drugs. Let's talk about the drugs which we use, you know, in the management of dementia. First is the cholinesterase inhibitors. Cholinesterase inhibitors. Okay. Now, basically, please understand this. In dementia, we see that there is a decrease in the, so in the etiology, we know there is a decrease in the acetylcholine. This also was asked in your exam. Okay. So, there is a decrease in the acetylcholine. Okay. So, we use drugs which are cholinesterase inhibitors. Okay. Cholinesterase inhibitors. Okay. Basically, what happens is acetylcholine is divided in, you know, it's broken down into acetyl and choline in the brain by this enzyme, acetylcholinesterase. तो अभी क्या है, what we are doing is हम इस enzyme को inhibit कर रहे हैं. So what will happen, क्या increase हो जाएगा, acetylcholine. So this is, you know, again you can remember, you know, अगर आपको mechanism याद है तो आपको etiology याद है. This question was asked based on, I will show you that question. So some drugs I want you to remember. Tacrin is a drug, you know, again it is banned. Can anybody tell me tacrin को क्यों ban किया है? Why it is banned? Yes, Nazish, very good. Yes, in the basal nucleus of minorette, very good. It is because of it is hepatotoxic. Okay, it is hepatotoxic. Very good. Yes. Okay. So yes, these drugs, you know, in dementias like Alzheimer's dementia. Alzheimer's dementia is the most common dementia. Is the most common dementia, right? So this is again important. Okay, Tacrin. Then drugs like donepezil, rivastigmine, galantamine. Again, all these are cholinesterase inhibitor. Cholinesterase inhibitors. Is it clear to everyone? Very good. Yes. Now, second drug is mementin. Now, also in the etiology, you can remember that there is an increase in the glutamate. Glutamate is basically neurotransmitter is neurotoxic. So, अगर glutamate increase हो जाएगा, so again it can damage the brain. It can cause dementia. So, basically mementin which is used, again it is a, what is the mechanism? It is a NMDA antagonist. देखो NMDA basically is a glutamate receptor. Very good. Yes, it is excitatory. Very good. Glutamate receptor. So basically अभी हमें पता है glutamate is in high, so we are using an antagonist. So you can again correlate the etiology again. So please remember these. And generally mementin is approved for moderate to severe dementia, moderate to severe cases. Okay, for moderate to severe cases. Okay. Now, one in particular, so there are various types of dementia. You can remember one particular type of dementia I want you to remember. Okay, just see this slide. Just remember, so you know dementias are cortical, you know dementias are cortical and subcortical dementias. Okay, so cortical dementias होते हैं और subcortical dementias are there. Let me write it. And subcortical dementias. Okay, yeah, like this. So dementias can be cortical dementias and subcortical dementias. So just remember some of these names. These names can be. देखो एक बार एक क्वेश्चन आया था, which of the following is not a subcortical, और उसमें ऑप्शंस थे पार्किंसन, हंटिंगटन, विल्सन एंड पिक्स डिजीज. देखो पिक्स डिजीज इज ऑल्सो, यू नो पिक्स डिजीज इज अनदर नेम फॉर फ्रंटोटेम्पोरल डिमेंशिया. तो नाम से यू कैन नो इट इज अ कॉर्टिकल डिमेंशिया. ठीक है, अल्जाइमर्स, फ्रंटोटेम्पोरल आर एग्जांपल्स ऑफ कॉर्टिकल, वाइल पार्किंसंस, हंटिंगटन्स, विल्सन्स, मल्टीपल स्क्लेरोसिस ये एग्जांपल है सब कॉर्टिकल डिमेंशिया के. अगेन सिंपली जस्ट दे कैन आस्क यू अबाउट द नेम्स. ओके, दिस इज अगेन इंपॉर्टेंट. और लुई बॉडी डिमेंशिया समटाइम मे हैव मिक्स्ड फीचर्स. ओके, इट हैज मिक्स्ड. Okay, it may be have cortical and subcortical, both features may be there. Now, Lewy body dementia is very, very important. Again, you can get a new question on this. 3 important features of Lewy body dementia I want you to remember. One is it has fluctuating cognition. So, cognitive impairment is there which is fluctuating, okay, like amnesia is there, okay, aphasia may be there. So, cognitive impairment. Please see, visual hallucination is there in the core criteria. Okay, हमने डिस्कस किया विजुअल hallucination they are common in organic mental disorder. यहाँ पे तो it is in the core criteria. So this is very important. And motor features of Parkinsonism. Motor features of Parkinsonism like tremors, rigidity, okay, bradykinesia, okay, bradykinesia they may be seen. Okay, so please remember Lewy body dementia which can come in the exam as an MCQ. Okay, is it clear to everyone? So just see, just have a look at these questions. Recently देखो आपके जून के questions हैं ये. Deficiency of which of the following, reason for cognitive impairment in old age? What will be the answer? Cognitive impairment they are talking about. What will be the correct answer? Can anybody tell me? The above question. What will be the answer? Yes, it is vitamin B12. It is vitamin B12. Is it clear to everyone? Very good. And an elderly male diagnosed with Alzheimer's disease. Alzheimer's is a dementia. Which of the following neurotransmitter is reduced? देखो, acetylcholine is also there and glutamate is also there. Can anybody tell? These are your FMG questions. So please see. Can anybody tell me what is the right answer? What is the answer? Yes, it is acetylcholine. Glutamate is increased. Okay, answer is acetylcholine. Is it clear to everyone? Yes, good. Okay, now let's talk about, so we talked about important organic mental disorders. Let's talk about psychotic disorders. First and very important is schizophrenia. Okay, first very important is schizophrenia. Can anybody tell me schizophrenia is more in males or females? Again, such questions may come. It is more common in males or females. Can anybody tell me? Yes, very good. All of you are very correct. The answer was B. Very good. Iska answer batao, it is more in males or females? Anyone? Male or females? In fact, it is nearly the same. We say it is nearly the same. Okay, it is nearly the same. And one of the important etiologies in schizophrenia is that there is an increase in dopamine in the brain. Again, there are multiple advanced theories are there, but you can remember initially there was a hypothesis, dopamine hypothesis, which was given and said that there is an increase in dopamine in the brain. Okay, so we'll talk, again we'll correlate with the treatment. Okay, so there is an increase in dopamine, and again other neurotransmitters are also affected, but again important one is dopamine. Please remember this. Right, now let's talk about the symptom criteria. So if you've seen this movie, it's okay if you have not seen the movie, just remember the name. देखो, I'm not saying कि इस movie में किसी को schizophrenia है, but if you remember the name will give you a mnemonic to remember the symptoms of schizophrenia. So the movie is Dhadkan. It's a Hindi movie. So if you remember the name, you will remember the. So I'm giving you a trick to remember the 5 symptoms: delusions, hallucinations, disorganized speech, catatonic or grossly disorganized behavior, and negative symptoms. Okay, so you remember the name, so to remember the symptoms. So these tricks will help you in the exams. Sometimes we think we are not remembering, so you can remember it with this mnemonic. Is it clear? Okay, Sunil Shetty, okay, maybe, okay, right. So let us say, okay, so let us talk about the criteria. So we know first is delusions, hallucination we have discussed. We already know kya hota hai delusion, hallucinations. Disorganized speech, basically we are talking about formal thought disorders, abnormality. So formal thought disorders, okay, like formal thought disorders we are talking about. Okay, so these 3 we already know. Let us talk about catatonic symptoms, then I'll come back to the criteria. Let us talk about what is catatonic symptoms or behavior and what are negative symptoms. Then I'll come back to the criteria. Again, this is very important. Many questions have been asked. Good evening, those who have joined now. Good evening. Now, catatonic symptoms, these are a group of motor symptoms. ये motor symptoms होते हैं which can be seen in the patient. So, like let us talk about these symptoms. Super is that there is significantly decreased psychomotor activity. Patient की psychic activity, जो patient की psychomotor activity, that is decreased. तो पेशेंट की माइंड इज ऑल्सो हैविंग लेस एक्टिविटी, माइंड की एक्टिविटी भी कम है और उसकी मोटर एक्टिविटी भी कम है. सो पेशेंट इज जस्ट मे बी लाइंग डाउन लाइक दिस, पेशेंट इज नॉट मूविंग मच, दिस इज स्टूपर. ओके, then mutism, again the name, as the name suggests, patient, just like you can mute the television, patient, the television screen is moving but you cannot hear anything, so there is a decrease in the verbal output, patient is speaking very less. Okay, so mutism is decrease, okay, in the speech output. Then two important symptoms, that is catalepsy and posturing, you can remember, both are both are similar. You can get a image based question like this from this topic. देखो catatonic symptoms में a lot of questions have been asked. Okay, this is very very important. So catalepsy और posturing both are basically odd posture. Just like in the image, patient ने बहुत abnormal एक posture maintain की है for a long time. So you may be given a picture like this and you may be asked what is this, it can be catalepsy or posturing may be there in the option. Difference is catalepsy is a passive phenomena. Passive means that patient himself has not come in this posture. Someone has made him sit like this and then he is maintaining this posture. So ये है catalepsy. And posturing is active, that means patient himself is come into this posture, only this is the difference. Okay, so option में generally they will give you just one, either catalepsy or posturing. So this is again important, a lot of image based questions are asked. Okay, so you should know this. Patient is standing on 1 feet for hours, this is again catalepsy or posturing. Then waxy flexibility. Waxy flexibility का मतलब क्या है? Person can be molded like a, patient can be molded like a wax candle. Okay, like a wax candle. Okay, okay. So molded like a wax candle का मतलब क्या है? Just like आप wax candle को जब mold कर रहे हो, initial there is resistance, after which you can mold the candle the way you want. Similarly, if you try to move the patient, there is initial resistance, after which you can mold the way you want. So this is waxy flexibility. ठीक है, ये है waxy flexibility. Negativism and automatic obedience, again we can discuss, compare them together. Negativism means patient has become very negative attitude. That means the patient oppose or give no response. So आप जो भी patient को बोलते हो, या तो patient उसको oppose करता है, वो उसका opposite करता है, या वो करता नहीं. You tell the patient कि आगे आओ, come forward, either the patient is standing, no response, or may go backward. ये negativism. Automatic obedience, as the name suggests, अभी patient क्या हो गया, इसका उल्टा, patient has become extremely or excessive cooperation is shown. ठीक है, अभी patient excessively cooperative हो गया, patient बोलो jump in the well, we will jump in the well, so he become extremely obedient. ठीक है, you can remember these symptoms, 2 symptoms like this. Okay, but it should be in odd, Jitu, it should be in odd posture. Okay, odd posture. Okay, now echolalia, again this was a question recently asked, question. Echolalia, again from the name you can, if you know the name you could have answered. Echolalia, echopraxia. What is echo or echo? Echo means to repeat, lalia means word. So basically echolalia is repeating the words. So you ask the patient, what is your name? The patient will say, what is your name? What do you do? What do you do? Where do you live? Where do you live? This is echolalia. Exactly this question was asked. Echopraxia means, echo means repeat. Can you tell me what is the meaning of praxia? Remember we read apraxia. Apraxia was lack of fine movement, loss of fine movement. Praxia matlab movement. Echopraxia means movement, repeat the movement. Suppose you're doing some this step in front of the patient will also start doing this dance step in front of you. So you start scratching your head, the patient will also start scratching your his head, not yours. Okay, so this is echopraxia. Okay, so this is echopraxia. Is it clear? These are some of the catatonic symptoms. A lot of question has been asked on catatonia. We'll talk about what is the treatment. I'll talk about I will talk about treatment of schizophrenia. Can anybody tell me what is the treatment of catatonic symptoms? What is the treatment of catatonia? This question again is also very important. What is the treatment of catatonia? Schizophrenia, we'll learn the treatment is, we'll talk about antipsychotics. But for catatonia, what is the treatment? Yes, very good. Lorazepam. Parenterally you can prefer and sometimes orally, but yes, parenteral lorazepam, okay, is the treatment of choice. Okay, and then also we can use ECT. Okay, ECT, what is ECT? Electroconvulsive therapy. electroconvulsive therapy. ECT also we can use. Okay, so this is again important. We'll talk about the treatment. Okay, so this is catatonic symptom. Then again, these are the questions which have been asked. Just see the questions. A patient when asked what is his name, repeat the same question again. What is the most likely phenomena? Again, what is this phenomena? Very good. Echolalia. Which is seen in catatonia? देखो catatonia. It is catatonia. So what is the answer? देखो it's an old cataplexy होता है या catalepsy? No, it is catalepsy. Positivism? No. Negativism? Disobedient? No. Automatic obedience. Answer again here is echolalia. So please remember these names. Is it clear? देखो वो cataplexy है, वो narcolepsy में मिलेगा. This was catalepsy. Catalepsy. Is it clear to everyone? So such beautiful questions have been asked previously. Okay, clear? Now next is negative symptoms. Negative symptoms of schizophrenia. Again, negative symptoms. Okay, now basically, you know, these negative symptoms, we say they respond, you know, poorly to treatment. Okay, negative symptoms generally they respond poorly to treatment. Okay, some of the negative symptom, one is anhedonia. Anhedonia क्या है? What is anhedonia? Anhedonia is, we have learned, it is decrease interest. So patient is not enjoying things which he would enjoy before. Then avolition. What is avolition? Decrease in the will or motivation. Family member say, sir, he does not do, you know, he does not show any will to do anything. कोई will power नहीं दिखाता. Avolition. Affect blunting, we have discussed already. What is affect blunting? Affect, so we have discussed flat affect or blunt affect. Decrease in the emotions. Decrease in the emotions. Asociality. Asociality. Okay. What is asociality? Decrease in the socialization. Family member says, sir, he does not socialize. Socialization he does not do. Go outside, does not talk to people. Decrease in socialization. And last is, next is alogia. Alogia, again, logos means word, alogia means decrease in the speech. Because everything is getting decreased. If you see, सब कुछ कम हो रहा है. So that is why they are known as negative symptoms. That is why हम इनको negative symptoms बोलते हैं. Is it clear to everyone? That is why they are known as negative symptoms. Right? Now let's go back to the criteria. Let's go back to the criteria. Now we say, according to DSM, 2 or more symptoms should be present in a patient. Out of these 5, at least 2 symptoms should be present, and you know, at least one symptom should be from the first 3. देखो पहले 3 में we have, that is why I have highlighted them differently. At least one symptom should be from the first 3. And what is the duration? Can anybody tell me? Duration according to DSM. What is the duration for how long the symptom should be present? They should be present for at least 6 months. Okay, at least 6 months, then we say it is schizophrenia. Is it clear to everyone? For yes, for ICD-11 we say it is 1 month. Okay, for ICD-11, until unless it is not specified, you can go with 6 months. Until unless they have specified and ask you according to DSM or ICD-10, then you can, ICD-11 you can go with 1 month. Okay, is it clear to everyone? This is okay. Is it clear? Now let's talk about the treatment. Let's talk about the treatment. Okay, now we use antipsychotics. We use in the treatment, we use antipsychotics. So we have 2 types of antipsychotic: first generation or typical antipsychotics, second generation or atypical antipsychotic. ठीक है, first generation है और second generation है, right? Now first generation, you know, has more EPS. These are extra pyramidal symptoms. We'll discuss about it. EPS. These are basically motor side effects. Okay, these are motor side effects, while these have less EPS. Okay, these have less EPS. While metabolic side effects like weight gain, diabetes, hypertension, hyperlipidemia, these metabolic symptoms are more with the second generation. ठीक है, basically mechanism of action, if you see, so which dopamine, which receptor, you know, we have neurotransmitter we have learned कौन सा increase हो रहा है? It is dopamine. So basically we are using antagonist, D2 antagonist. Okay, D2 antagonist. Okay, so first generation mechanism of action, these are D2 antagonist, while Second generation, they are D2 and 5-HT2A. 5-HT basically is serotonin, 2A antagonist. Okay, antagonist. Is it clear to everyone? You can remember it is 2, both are 2, so 2 and A, you can remember A for atypical. Okay, 2A. Okay, you can remember like this. Very good. 2A. Is it clear to everyone? Again, please remember now. So certain, some of the drugs you can remember. In first generation, there is chlorpromazine, haloperidol. Okay, these are some of the first generation. In second generation, olanzapine, risperidone, aripiprazole. Again, one question was asked in the recent exam. Aripiprazole's mechanism of action is slightly different. It is a partial D2 agonist. It is a partial D2 agonist. Again, this question was asked in your exam. Okay, so aripiprazole is partial D2 agonist. Is it clear? Partial D2 agonist. Another important drug is clozapine. Okay, clozapine. Okay, let's discuss some important points about clozapine. Okay, now clozapine again, is a second generation antipsychotic, but we, please remember it has a D4 affinity is much more than D2. Okay, D4 is more than D2. Okay, most common side effect is sedation. Okay, most common side effect is sedation. So please remember, this is an important point. Please remember, clozapine is reserved for only treatment resistant schizophrenia. That means, suppose a patient comes to me for the first time, he is having schizophrenia and he is never being treated. So क्या मैं clozapine patient को दूंगा? Will I give clozapine? Will I give clozapine to the patient? Anyone? No. Clozapine is only given for treatment resistant. That means if suppose patient has been tried on 2 antipsychotics, 2 different antipsychotics and no response, less response, then we can give clozapine. Why it is reserved for TRS? Because it has some serious side effects. Very good, Jasmina. Yes, very good. So please remember some serious side effect with the mnemonic SAM. One is seizures. It can cause seizures. Okay. It can cause agranulocytosis, decrease in the WBC count, especially the neutrophil counts. Okay, decrease in the neutrophil count. So there is infection also, and yes, it can also cause myocarditis. So please remember these serious side effects. Okay, these are serious side effects. Now I told you that second generation have metabolic side effect. Clozapine has maximum weight gain. Okay, it has maximum weight gain. Okay. Now another point is, clozapine is one antipsychotic which has anti-suicidal, very good, suicidal property. Now it does not mean that I will use it for, patient having suicide, but it has an anti-suicidal property. Okay, it has a anti-suicidal property. Again, this is important. Okay, so this is important. Okay, and also it is one of the drug with least EPS. Very good. It is the drug with one of the least EPS. Extrapyramidal symptoms are, less with clozapine. Okay, so these are some important points about clozapine. Please remember this. Okay, please remember these points. Okay, now some extrapyramidal symptoms. Let's talk about extrapyramidal symptoms, EPS. So I'll just briefly discuss. One is acute dystonia. Acute dystonia मतलब क्या है? Sudden muscular contraction. Patient को आपने generally this may occur if you have given someone parenterally or even orally. Okay, it is sudden contraction. For example, patient may come like this, sir, I am not able to move my neck. What is this? Torticollis. Or there is uprolling of the eyes. Patient is not able to move his eyeball. They are just uprolled upwards. Okay, so this is oculogyric crisis. Okay, so these are, this is one of the earliest of EPS. और ट्रीटमेंट कैसा होता है? हाउ डू वी ट्रीट? वी ट्रीट विद एंटीकोलिनर्जिक ड्रग लाइक प्रोमिथाजीन. जनरली वी गिव इट पेरेंट्रली. ओके, वी गिव IV or IM, we give parenterally. Okay, so this is acute dystonia, oculogyric crisis. Very good. Then patient may also have drug induced Parkinsonism. Okay, so patient comes to you with tremors. After you start of antipsychotic, patient is consuming antipsychotic, comes with tremors, rigidity, bradykinesia, so Parkinsonism like symptoms. Again, treatment is anticholinergic drugs like trihexyphenidyl. Very good. Yes. Next is akathisia. Akathisia is basically restlessness, inner and outer restless. Patient says, sir, मुझे बहुत restless feel हो रहा है from inside, and patient is also appearing very restless. Patient is being very fidgety. He is tapping on one feet other. Patient बार बार move करे, is appearing very restless. This is akathisia. This is akathisia, and please remember it is the most common EPS. It is the most common EPS, and the drug of choice is propranolol. Again, this has been asked, propranolol. Okay, this is propranolol. Is it clear? Next is tardive dyskinesia. Tardive means long term. So someone who is taking antipsychotics for a long duration may develop some dyskinesias. Dyskinesias means abnormal movement. So tardive dyskinesia. Okay, so for example, the patient may have trunk protruding movement, or continuously chewing movement. Okay, or there is some hand movements. Okay, so this is tardive dyskinesia. Again, treatment is drugs like valbenazine or tetrabenazine. These basically decrease dopamine depleters. Okay, so these can be used. And lastly, one very important and serious, again very important and emergency condition, neuroleptic malignant syndrome. Okay, here the patient may have increased temperature, the CPK levels are also increased, rigidity, sweating, diaphoresis is there. Okay, there is tachycardia, tachypnea may be there. Okay, so neuroleptic malignant syndrome. Okay, and again here the treatment is a skeletal muscle relaxant, dantrolene. Okay, dantrolene. Okay, now here even there is myoglobinuria. Okay, which can lead to renal failure and even death of the person. Okay, so again this is important. These are important EPS, extrapyramidal symptoms. Yes, bromocriptine also can be used. Okay, bromocriptine can be used, but yes, the treatment is, if you have to choose one, then that is dantrolene. Okay, is it clear? Then it is dantrolene. Is it clear? So agonists like bromocriptine we can also use. Right, now let's talk, we talked about schizophrenia, let's talk about some other psychotic disorders. Okay, again these are small topics, but recently a lot of questions have been asked. First is, so in the other psychotic disorder, let's talk about acute psychosis. Dekho, acute psychosis, as the name is telling you, acute, duration is less, symptoms are similar to schizophrenia. Okay, but duration is less than 6 months. Okay, so someone comes to you with symptoms of delusions, hallucinations, let us say for 10 days, 15 days, 20 days, that is acute psychosis. One interesting point I want you to remember is that many a times there may be a stressor may be present. It can be a life event. So patient comes, patient has failed in an exam, or there is a breakup after which the symptoms have developed, or this stressor can also be like fever. So this is again important. देखो, एक patient है, acute sudden onset of symptoms. Let me give you sudden onset of symptoms. Patient को delusions हैं, hallucinations हैं, abnormal behaviors is there. Okay, abnormal behavior is there, and patient is also having, let us say, fever. So what all important diagnosis will come to your mind? This is again very important. क्या diagnosis, which diagnosis will come to your mind? Yes, of course, there can be acute psychosis. देखो, fever is there. Many a times जब हमें fever दिखता है, we start thinking about something organic. So it can also be, another possibility can be delirium. But for delirium, what should be the important symptom? Which symptom should be present? Then we say that this is delirium. Can anybody tell me? क्या symptom होगा जिसे हम delirium कहेंगे? For delirium, what is the important symptom? If you have to choose delirium as the answer, there should be impairment of consciousness. देखो, so this is again a very important point. But here there is no impairment of consciousness. So here then we say it is acute psychosis. So both acute psychosis and delirium, they occur suddenly. Acute onset of symptoms are there. Okay, so again you should know how to differentiate. Very good. Altered sensorium, very good. Yes, nanny, shop, night, very good, very good. Okay, so again this question was asked in your exam. A female failed in the exam. She suspected teachers are conspiring against her and she is also hearing their voices since 15 days. Since few days it was mentioned, okay, let us say 15 days. So teachers, you know, are conspiring, ये क्या हो गया? Delusion. She is also hearing their voice, ये क्या हो गया? Hallucination. And एक stressor भी दिया है. Sometimes it may be given, it may not be given. So answer is acute psychosis. Is it clear? Acute psychosis. Next is delusional disorder. Next is delusional disorder. Again, the name is telling you what is delusional disorder. Simple, there is one or more delusions. Okay, patient को there is one or more delusions. Okay, so this is delusional disorder. सिर्फ delusions है patient को. देखो schizophrenia के diagnosis के लिए we have learned that it should at least 2 symptoms should be there. Here the patient is just having delusion, then it is delusional disorder. Again, you know, simple question was asked in your 2021 exam. A patient since 3 months believe that his daughter wants to kill him. What is the likely diagnosis? So क्या diagnosis होगा इसका? Anybody? Can anybody tell me what is the diagnosis? What is the diagnosis? So there is only delusion of persecution. So answer is it is not schizophrenia, because schizophrenia at least 2 symptoms should be there from the 5. Okay, it is delusional disorder. Okay, so again these psychotic disorders, simple questions have been asked. Please remember the concept. Okay, I hope it is clear. Very good, very good. Dipali, Vish, Nani, very good. MS, Vikas, very good. So this we have discussed psychotic disorder. Okay, now mood disorders. Let's talk about. So basically, what are mood disorder? There is abnormality of mood is there. There is abnormality of mood. Let's talk about the first important disorder, that is depression. Can anybody tell me? No. Depression, also known as major depressive disorder. Depression is more common in males or females? Okay, we'll talk about this, Jasmina, when we'll talk about personality. Okay, right. So depression is more common in males or females? It is more common in females. Now, important neurotransmitters in the etiology, I want you to remember, there is a decrease in serotonin, there is decrease in norepinephrine. Okay, yes. Okay, and also, you know, there is also decrease in dopamine. But if you have to choose 2 important neurotransmitters, the first 2 will be important. Okay, अगर आपको 2 चुनने हैं, you have to choose 2. The decrease in serotonin and norepinephrine is important. Even dopamine is also decreased. Okay, is it clear? Yes. Now again, symptoms, you will get this, symptoms. For how much duration the symptom should be present? Can anybody tell me? For how long the symptom should be present? What is the duration? What is the duration? The duration is 2 weeks. Okay, and you can remember it with the mnemonic SIGE caps. You can remember with the mnemonic SIGE caps. Okay, you can remember it with the mnemonic SIGE caps. So basically, patient has sad mood, patient feels depressed. There is decreased interest, जिसको हम we also call it as anhedonia. There is feeling of guilt or worthlessness, that I am good for nothing, I am a bad person. Okay, there is low energy. Okay, low concentration. Patient has low concentration. Many times they complain with forgetfulness. Sir, I am forgetting things. So this is also termed, you can remember this term, pseudo dementia. This is not true dementia. This is because of lack of concentration. They are not able to remember things. So they say, forgetfulness may be the complaint. Okay, then appetite may decrease or increase, and corresponding weight may be increase or decrease. Then psychomotor retardation, agitation, suicidal thoughts may be there, and sleep disturbances like insomnia and hypersomnia. Okay, so these are the symptoms. Okay, so present for more than 2 weeks, 2 weeks or more, then we say patient has depression. Okay, then we say that the patient has depression. Clear? Yes, there is a cognitive Beck's cognitive triad. Cognitive triad is there. Okay, it says that patient has worthlessness. Worthlessness means patient has negative feelings about himself. I am good for nothing. Okay, patient has helplessness. Helplessness, patient feels, nobody can help me, nobody can help me. Helpless, patient feels helpless. And there is hopelessness. What is hopelessness? Hopelessness is negative views about the future. There is no hope in the future. So these are Beck's cognitive triad. Hopelessness, again we will discuss the importance in suicide. Okay, so this is Beck's cognitive triad. Worthlessness, very good. Yes, correct. Now Now, after making a diagnosis of depression, sometimes what happens is there are some extra symptoms for which we add some specifier. Again, this is important. Many questions have been asked from this topic. Okay, so we add some specifier. For example, we say patient has MDD along with whatever the extra or unique symptom patient is having. तो पेशेंट को डिप्रेशन है, ये डायग्नोसिस हमारा बन गया. दिस इज अगेन वेरी इंपॉर्टेंट फॉर योर एग्जाम्स. प्लीज हाईलाइट दिस पॉइंट. फर्स्ट इज डिप्रेशन विद साइकोटिक सिम्टम्स. पेशेंट को डिप्रेशन है. Okay, let us say since 1 month he is having depression. Now the patient also suspects that neighbor wants to kill me, or he is hearing the voice of neighbor telling him that he is a very bad person. So then we say it is depression with psychotic symptom. Why it is important? Because it will also change the treatment. What will be the treatment now? We will give antidepressant along with antipsychotic. This is a very important point. You can get directly questions like this. This is, देखो, mood disorder में recently a lot of questions have been coming from the treatment. I'll talk about this. This is very important. Please remember this point. देखो, we talked about catatonia in schizophrenia, but that does not mean कि catatonia is a only seen in schizophrenia. In fact, catatonia is more commonly seen with mood disorders. Okay, so patient along with depression can also have catatonic symptoms. So depression plus catatonic symptoms. How will you treat? Suppose they say patient is having depressive symptoms and patient is having mutism, catalepsy, posturing, echolalia, yani catatonic symptoms. So treatment, please remember, you will also give here lorazepam. Okay, for catatonic symptom we have discussed, or ECT, electroconvulsive therapy. Okay, देखो ECT nowadays, ECT we give modified ECT. Nowadays ECT we give modified means, we give, patient is under anesthesia. Okay, anesthesia, as well as we give muscle relaxants. Okay, abhi hum direct ECT has been banned. We'll talk about this. Okay, so of course we will also add antidepressant, but main treatment, again, if they ask such question, they are asking about how will you treat catatonic symptoms. How will you treat catatonic symptom? Is it clear to everyone? Yes, Kishore, very good, MS. Yes, correct. Yes, is it clear to everyone? Modified, yes, Kishore, very good. So, and the third, another important specifier is postpartum onset. That means depressive symptoms if the patient develops during pregnancy or within 6 weeks of delivery. Within 6 weeks of delivery, then we say that the patient has postpartum onset, or it is also known as postpartum depression. Postpartum depression. Okay, yes, Nani, we give lorazepam. Okay, देखो, there are 3 important terms I want you to remember: postpartum blues, postpartum depression, and postpartum psychosis. Please remember these few important points. One is postpartum blues. It is a transient, symptoms, emotional and behavioral symptoms. Transient emotional and behavioral symptoms. So these are transient. There is no definitive treatment, just supportive management is enough. So symptoms like patient after delivery within few days, like 3 to 5 days. So onset is generally within 3 to 5 days of delivery. Patient is having excessive crying, complaining of decreased sleep. So these are milder symptoms and they generally go away on their own. These are transient. So no specific treatment is required. Okay, these are postpartum blues. This was your NEET PG recently asked question. In postpartum blues, this was asked in your FMG exam. In postpartum blues, more of severe symptoms. Okay, like anhedonia, suicidal thoughts. Okay, maybe there, and more, again, suicidal thoughts may be there, and more duration may be for longer time. Yes, treatment is required. We'll talk about the treatment. Okay, for this postpartum depression you have to treat. Okay, so suicidal thoughts, severe symptoms, if they are seen, then it is postpartum depression. Sometimes don't go with the duration, symptoms are more important. And many a times patient may develop delusions or hallucination. Many times they may say they are hearing voice to kill the baby. Okay, or they they may say that this I have not delivered. They may develop delusion that I have not delivered any baby, okay, then we say it is postpartum psychosis. Okay, so this is again important. Many questions have been asked: postpartum blues, depression and psychosis. Is it clear? Okay. Now then in the treatment, again many questions have been asked on the treatment. Okay, in the treatment, so we have drugs and we have therapy. Okay, we have drugs and we have therapy. In the drugs, the treatment of choice are the SSRIs, selective serotonin reuptake inhibitors, because of less side effects. Okay, so you should know, I have given the names, you should know, because many times they ask the names like sertraline, fluoxetine, paroxetine, okay, citalopram, vilazodone. Generally also in pregnancy we can give, one important point I want you to remember is P for paroxetine. P you should avoid in pregnancy, avoid in pregnancy. It has some teratogenic effect. It can lead to cardiovascular defects in the baby. Okay, it can lead to cardiovascular defects in the baby. This is again an important point you should remember. Okay, and many of these SSRIs in pregnancy, they may cause, again, it is very, less frequently seen, the incidence is very low, but still in pregnancy if you give, they can cause persistent pulmonary hypertension of the newborn. Okay, okay, again incidence is low, so again we tend to give SSRIs in pregnancy, but yes, you should not give paroxetine. Okay, you should not give paroxetine. Again, these are some important questions. Again, various side effects are also there of sertraline, like it can cause nausea, it can cause vomiting, diarrhea. Okay, these are, then sexual side effects are also there. Sexual side effects are there. Okay, sexual side effects are there. Vivid dreams are there. Okay, sweating is there. Okay, hyponatremia, again hyponatremia, especially in elderly. These are some important side effects, which you should remember. Okay, sexual side effects, again we will learn in the treatment. In sexual disorder, we'll talk about the use of this side effect. Okay, so these are drugs. Now next important category of drug is the SNRI. Again, you should know what is SNRI. These are serotonin norepinephrine reuptake inhibitor. Because serotonin is low, norepinephrine is low, so we are trying to increase with this drug. So this question was asked in your FMG exam. A psychiatrist has prescribed a medicine to a patient of depression which is increasing norepinephrine and serotonin. Which of the following is the drug? So basically they are indirectly asked you which of the following is an SNRI. The option, one of the option there was venlafaxine. So this is again a previously asked question. A lot of question on the management they are asking. Then there is desvenlafaxine, duloxetine, milnacipran. These are some important drugs. Okay. Then there is NDRI, okay, that is norepinephrine dopamine reuptake inhibitor. One important drug is bupropion. Again, this drug, we will talk about this antidepressant used in smoking cessation. That is bupropion. This question also was asked. Clear? Now in the TCA, again, there is another, antidepressants. One important point about TCA I want you to remember, this question has been repeated multiple times. TCAs are basically tricyclic antidepressants. Generally we tend to not commonly use them, less often we use it. Now in the TCA talks, because of the side effect profile, and in the toxicity, again question on toxicity has been asked, especially the management. So TCA toxicity can cause, please remember, they can cause CNS symptoms like altered sensorium, convulsions are there. CVS symptoms like there is hypotension, tachycardia, ECG abnormality, QRS complex may be more than 100 milliseconds. Then autonomic nervous system, again because of anticholinergic side effects, anticholinergic property, urinary retention, dry mouth, these symptoms can occur. Okay. Now also it causes metabolic acidosis. Now generally in the treatment, when they ask, especially when the ECG, the QRS is more than 100 millisecond, what is the treatment? This again is important. The treatment is sodium bicarbonate. Okay, sodium bicarbonate. This is again has been asked in few exams previously. Okay, so please remember this. Please remember this. Is it clear? So this is again important. Okay. Now next is, so one was drugs. One is drugs. We treat depression with drugs. Then the other is we also do therapy. CBT. Okay, we also do CBT. right? Now again, you know, this is again a recently asked question. So for mild depression, if the question was for mild depression, generally, you know, again we use drugs and also we use therapy. For mild depression, what will you do? For mild depression, you can start with CBT. What is CBT? Cognitive behavior therapy. So there is a lot of abnormality in thinking, negative thoughts occur, that is cognitive problems are there. Okay, so we try to change that, you know, cognition. Okay, so cognitive behavior therapy. For moderate to severe, this was again a FMG question. Patient is having mild depression. ये question था mild depression, so answer was CBT. Moderate or severe, again then you will start with drugs. We will give drugs, again we can also give CBT. Okay, plus minus we can also give CBT. Okay, so this is again important. Okay, this again next important question. Patient is having depression. Patient is having depression with suicidal thoughts. Patient को depression है with he is having suicidal thoughts. What will be the treatment of choice? This is again very important question. Answer will be ECT, electroconvulsive therapy. So ECT for suicidal thought. Even if, you know, suppose they say patient is pregnant, she is having depression and she is having suicidal thoughts, then also even in pregnancy we can give ECT. I am telling you this because sometimes in the question we tend to think, arey, pregnancy mein how will we give ECT? No, it can be given. Okay, so this is important. Please remember this point. This is again very, very important. Clear? Next is bipolar disorder. Next is bipolar disorder. Okay. Now in bipolar disorder, yes, it is safe. Yes. Now bipolar disorder is basically bipolar 1 disorder. Patient is having depression plus mania. So patient को depression के episodes हैं और mania के episodes हैं. So bipolar 1 disorder is depression plus mania. Okay. Bipolar 2 disorder is patient is having depression plus hypomania. Yes, very good. MS हमने डिस्कस किया. डिप्रेशन में अगर कैटाटोनिक सिम्टम्स है देन ऑल्सो लोराजेपाम के बाद नेक्स्ट ऑप्शन वी हैव ECT. वेरी गुड. ओके, तो बाइपोलर 1 विल टॉक अबाउट व्हाट इज मेनिया एंड हाइपोमेनिया. बाइपोलर 1 में डिप्रेशन है और मेनिया, एंड बाइपोलर 2 में डिप्रेशन एंड हाइपोमेनिया. प्लीज रिमेंबर, इवन इफ पेशेंट इज ओनली हैविंग एपिसोड ऑफ मेनिया, that also is considered now under bipolar disorder. Bipolar disorder. Okay. So basically, what are the symptoms? You know, what are the symptoms of mania? Let's talk about the symptoms of mania. So again, you can remember what is the duration. Yes, we'll talk about this. We'll talk about this rapid cycling. Duration of mania is 1 week. देखो, depression की थी 2 week. मेनिया की है 1 वीक. अगेन यू कैन रिमेंबर इट विद द निमोनिक. मेनिया में बेसिकली क्या हो रहा है, पेशेंट इज वेरी हैप्पी और इरिटेबल, पेशेंट इज हैविंग लॉट्स ऑफ एनर्जी. सो द निमोनिक इज मी डिग फास्ट. मी इज, यू नो, अगेन मूड इज ईदर एलिवेटेड, पेशेंट इज वेरी वेरी हैप्पी विदाउट रीजन, और इज इरिटेबल. एनर्जी लेवल्स आर वेरी हाई. ओके, देन डिग, पेशेंट इज वेरी डिस्ट्रैक्टेबल. यू नो, पेशेंट में डू मैनी थिंग्स, start something and then, you know, start something else. So they may shift their, you know, attention. They are very very impulsive, very very impulsive. You know, they may do impulsive act like, you know, overspending. They spend a lot, or you know, they may do over socialization, or their religious activities increase. You know, family members say, sir, pure din he is just doing, you know, bhajan and kirtan, nothing else. They become over religious, or their sexual activity may increase. They become, you know, they may have grandiosity, you know, they have inflated self-esteem. Okay, that they are very very important. Then fast, I have already discussed. Flight of ideas can be seen, activity levels is increased. Sleep, again very interesting, there is a decreased need of sleep. You know, they say I don't require sleep, and they also may have talkativeness. Okay, so these are the symptoms for mania. Okay, duration, please remember 1 week. Now sometimes patient with mania can also develop delusions or hallucinations. Then we add this specifier. Okay, so you know, if you are talking to God, that is normal, but patient says now God has started talking to me, I can hear the voice of God, God is talking to me, then it becomes abnormal. So he is having hallucination, he may think I am the richest person on the, you know, on the planet, so he has developed delusion of grandiosity. So then we say it is mania with psychotic symptoms. Okay. Then what is hypomania? Hypo, as the name suggests, देखो mania से थोड़ा कम severe है. Hypomania is slightly less severe than mania. Duration is 4 days. Okay, hypomania की duration क्या है? 4 days. Okay, so symptoms are similar to mania, but they are less severe. Okay, severity is not that much. So the functional impairment is not marked. देखो mania के patient को अगर if you ask me his functioning, he will be very impaired. He may not be able to do any occupational work or social activities. But here because symptoms not very severe, तो जो functional impairment है वो ज़्यादा नहीं है. Okay. Now one important point about hypomania I want you to remember is, in hypomania you will not have flight of ideas. Flight of ideas will not be seen in hypomania. Please remember this. And also psychotic symptoms also like delusions and hallucinations will not be seen in hypomania. अगर वो मिल रहे हैं तो again it is mania. Okay, it is mania. Is it clear to everyone? Is it clear to everyone? Now in the treatment, now let's try to talk about some important points about the treatment. So we have let's talk about treatment of mania or hypomania and depression in bipolar disorder. Now first step, one important point I want you to remember, the first step when you treat mania or hypomania. देखो, suppose you have a patient, let us talk about this situation. You have a patient जिसको पहले depression था and now the patient is having mania or hypomania. Suppose this is, and patient was treated for this depressive episode. What will be the first step? What will be the first step in the treatment? This is very, very important. The first step will be that you have to stop antidepressant. This point has been asked many times. Okay, so they will give you a scenario in which patient को mania है, past में depression था and he was on treatment. What will be the first step? Before starting anything, you have to stop the antidepressant because antidepressant will elevate the mood. Patient mood is already so much elevated. You have to stop antidepressant. Then coming to the drugs, we have three first line drugs. We can use antipsychotics, we can use lithium, we can use valproate. Okay, so again these are all the first line. Of course अगर patient को मान लो psychotic symptoms है, so you will definitely go with antipsychotics. Lithium and valproate are known as mood stabilizers. Okay, they are known as mood stabilizers. Okay, now one very important point, this question has been repeated many a times in pregnancy. Suppose a patient is pregnant and she is having mania or hypomania. What will be the treatment now? Which drug will you choose? Can anybody tell me कौन सी drug choose करोगे? You will prefer antipsychotics over lithium, over valproate. Yes, if you have an option to give antipsychotics are the safest in pregnancy. But अगर antipsychotic नहीं दिया option में, then you will go with lithium. Try not to use valproate. देखो, so please remember, even lithium also has teratogenic effect. देखो, lithium का भी teratogenic effect है, that is abstain anomaly. ठीक है, lithium can cause abstain anomaly. Okay, but again the incidence is low and again it can also be repaired, so we can still give lithium. But valproate, what is the teratogenic effect? What is the teratogenic effect of valproate? It causes neural tube defect. Okay, in fact another mood stabilizer, carbamazepine also has neural tube defect as the teratogenic effect, carbamazepine. Okay, so please remember, this is very, very important. This slide is very, very important. A lot of MCQs have been asked. Okay, is it clear? Yes. Now then, if the patient is in bipolar disorder, patient is having depression. So suppose patient को पहले mania या hypomania था, now patient is having depressive episode. This is known as bipolar depression. देखो, never use antidepressants alone. Never ever use antidepressant alone in such patient, because आपने antidepressant अगर alone दिया, there is chances of switch. There are chances of switch. Switch मतलब patient may go to mania or hypomanic state. So never use antidepressants alone, never ever. If you have to give antidepressants, add a mood stabilizer. This is again a very important point. Very, very important point. Okay, then now it is seen, the combination of fluoxetine and olanzapine has been shown to have very good effect, effect. So this is one of the important combination. Then we can also use lithium. Lamotrigine is also a mood stabilizer, but is only used for depression. Please remember, देखो lithium was also used for mania, but lamotrigine is a mood stabilizer which is only used for depression. Okay, so this point is very important, that don't use antidepressants alone. Please remember this point. This is again very important in the treatment. Now then there is something known as rapid cycling. This is again an old MCQ. What is rapid cycling bipolar disorder? This is very important. So in rapid cycling we have 4 or more episodes of depression, mania or hypomania in how much time? Can anybody tell me? कितने टाइम में होगा? In 1 year. This is your FMG exam question. So suppose this is 1 year duration. ये 1 year duration है. Okay. Patient had an episode of, let us say, mania, then depression, then let us say hypomania, then another episode of depression. At least 4 episodes have happened in 1 year. This is rapid. So rapidly patient is going up and down. This is rapid cycling bipolar disorder. Again ये आपका पुराना MCQ question है. This is very important. Is it clear to everyone? Very important. Now another last topic in this is suicide. Suicide, again the rate of suicide, why it is important, because recently it has gone up to 12. Okay, according to the latest NCRB, National Crime Reports, Bureau, NCRB data, it is 12 per 1 lakh population. Abhi tak, it was in 10s, or now, lastly it was in 11. It has reached to 12, very high level. Okay. Most common mode of suicide is, anybody? Most common method of suicide is hanging. Okay, in India, we're talking about India. Now, risk factor. This is again important. Most important risk factor for suicide. If this factor is present, you should be very careful. Can anybody tell me what is the most important risk factor here? It is previous suicide attempt. Okay, so previous suicide attempt. So if patient had a previous suicide attempt, it is the most important risk factor. Another important risk factor जो हमने discuss किया is hopelessness. Patient से आप पूछते हो, patient से, sir I think tomorrow is very black. कल किसने देखा? I don't think anything good will happen. Patient having hopelessness, again it's an important risk factor. Okay, this is again important. Please remember this. Then there are some other risk factors like male, especially elder age. देखो, again is a higher risk factor. Okay, then patient having some chronic illness, and so many other risk factors may be there. Okay, patient is having some chronic illness, then patient is having substance abuse. Okay, so these are some important risk factors. Is it clear to everyone? These are again very important. Okay, these are very important. Is it clear? Right. Now, so again these are all previously questions that has been asked. Pregnant female on lithium, she visits for antenatal checkup, which she is at, the fetus is at greatest risk. It is Epstein anomaly. Is it clear? Again these are all recently asked question. A pregnant female having bipolar disorder, which of the following drugs should be avoided? Dekho, this is a very interesting question. Here they have not given valproate. Otherwise valproate would have been the answer. Haloperidol, risperidone, we know these are antipsychotics. Lamotrigine again is also not, the teratogenic risk is not that high. The answer will be lithium. Lithium causes Epstein anomaly. Is it clear? This is again very important. Please, you should know such questions. These are asked again and again. Clear? Very good. Tanmay, Vish, MS, very good. Now, briefly I'll talk about anxiety disorders. Again, many questions have been asked. So anxiety disorders, what we can do is we can divide into 3 categories. One is panic disorder. Okay. Then the next 3 we can divide as situational. That means the anxiety is occurring only when there is a particular situation. Agar wo situation hai, तो anxiety है, नहीं तो नहीं. Okay, and then there is generalized anxiety disorder. Okay, so panic disorder is basically, so सब में anxiety is the common symptom. So anxiety is basically a vague sense of feeling with tremors, palpitation, restlessness, sweating. These are some physical symptoms जो anxiety disorders के साथ होते हैं. Is it clear to everyone? So basically in panic disorder there is a sudden onset of intense anxiety. suddenly there will be anxiety with one very important. So anxiety में क्या क्या symptoms होंगे? There will be palpitation, sweating, there will be shortness of breath may be there, nausea like feelings may be there, tremors may be there. उसके साथ और क्या important point है? Okay, so what is important? Feeling of impending doom. There is feeling of impending doom. Patient को ऐसा लगता है कि कुछ होने वाला है, something is about to, I am about to die. So this is again important. Okay, then in situational anxiety, there will be anxiety in particular situation. For example, agoraphobia में the anxiety should be in 2 or more situations, like patient is in using a public transport, okay, or patient is in there is closed space, open space. So there are certain situations in which the patient will develop anxiety. Then again specific phobia, again patient has anxiety towards some object or situation. किसी को that they have anxiety, phobia for cats, phobia for dog. So that is specific phobia. And social phobia is when the patient has anxiety for certain for some social situations. So जब भी situation में anxiety होगी, you think of these disorders. And in generalized anxiety disorder, there is one important point. देखो, generalized anxiety means anxiety is persistent, continuously anxiety हो रही है. So in the question, patient has a lot of, there is excessive worries. This question has been asked in your exam. Patient को excessive worries हो रही हैं. Okay, so when patient has excessive worries, that means patient is having generalized anxiety disorder. Again, this is important. Okay, this is again an important slide. Okay, so again panic disorder questions have been asked, many questions have been asked on this. Okay, so this is generalized, these are the anxiety disorder. Next is post-traumatic stress disorder. Okay, in post-traumatic stress disorder, what is happening is in PTSD basically there is a stressor. देखो नाम से ही पता चल रहा है कि there is a stressor. There is so after trauma patient has developed a stress disorder, PTSD. Okay, so there is a stressor. So the stressor is a very major life threatening stressor. Please remember, कोई छोटा मोटा stressor नहीं है, it's a very big stressor. Like patient had an accident, या patient was kidnapped, or war, he has experienced war. Okay, जैसे in Ukraine there is a war, so people might have PTSD. Natural there is a natural disaster like flood, tsunami, or history of abuse or some serious illness. Many a time this accident is given in the question. देखो, तो in for PTSD पहले तो एक stressor होना चाहिए. Okay, and what are the symptoms for PTSD? The duration of symptoms should be for 1 month. The duration should be for 1 month. Okay, yes, they have given yes. Now to remember the symptoms, you can remember it with the mnemonic MAHI. Okay, when Mahendra Singh Dhoni bats, he is a trauma for the opponent. आप ऐसे याद कर सकते हो. Okay, so there are mood and cognitive symptoms. ठीक है, mood symptoms, negative mood हो जाता है patient का accident हुआ, उसके बाद patient has developed depressive mood, or patient has developed negative thoughts कि I am a very bad person, I am good for nothing. Okay, now very important symptom which you should look for is avoidance. Okay, so patient starts avoiding memories or feelings, or the patient starts avoiding objects or people. So जहाँ पे accident हो वो वहाँ नहीं जा रहा, he is not using the car in which he had accident. Okay, so there is avoidance symptom. Then hyperarousal symptoms are there. Okay, and another important symptom is intrusion symptoms, re-experiencing symptoms. Okay, patient को flashbacks होते हैं, flashbacks. Okay, patient may have flashbacks. So look for these avoidance symptoms and intrusion symptoms to make the diagnosis of PTSD, although all the 4 should be present. In the treatment, we do CBT. Okay, so CBT is the therapy, and also we can give SSRIs, drugs like SSRIs, right? We can use. So this is PTSD. Let's talk about the next important topic, that is obsessive compulsive and related disorder. Okay, let's talk about OCD. Again, many questions have been asked from this topic, OCD. Now, so let's talk about so basically it has and related disorder. What has been done is a lot of disorders have been added into this common category. So let's talk about the first important disorder, that is OCD. पहला क्या है? OCD. So in OCD we have obsessions and compulsions. Okay, so there are obsessions and compulsions. So you can remember obsessions like this. with the mnemonic ROSY. Remember it with the mnemonic ROSY. What are the characteristics of obsession? They are some repetitive thoughts or images or impulses. Patient को बार बार कोई repeated thoughts आ रहे हैं और images और impulses आ रहे हैं उसके mind में, which patient knows that these are his own. Patient says, I know sir, these are my own thoughts, but these are senseless thoughts. ये senseless thoughts हैं, they don't have any meaning and I am not able to control them. These are irresistible. Okay, so this is how we categorize obsession. So patient says, I am having repeated thoughts that my hands are dirty. Sir, I know, so sir, for 2 hours, 4 hours, 8 hours, I am getting these thoughts in a day. They are very repetitive. I know these are my own thoughts, but these are senseless. Sir, look at my hands, they are very clean. I've just washed them back, few minutes back. And I want to control them, I am not able to control. These are irresistible. This is how we characterize, these are the characteristics of obsession. And compulsions are basically repetitive acts. These are repetitive acts which the person do, okay, repeatedly. Again, OCD is more common in males or female, we say nearly the same. Most common comorbidity with OCD, you should remember, is depression, okay, is depression, okay. So this is again important, okay. So there are various types of obsessions, you should know. Most common obsession is contamination. Second most common is pathological doubts. So patient has doubts whether I bolted the door or not, whether I have turned off the gas knob, okay. So they are pathological doubts. Then patient may also have obsessions of symmetry. Everything should be placed symmetrically. सब कुछ symmetry में होना चाहिए, okay. Then patient may have aggressive obsession. Sir, I get repeated thoughts to slap someone. I don't want to slap, but I am getting these repeated thoughts. Or sexual. Sir, I get repeated thoughts to touch someone inappropriately. I don't want to do, but I am getting repeated thoughts. Okay. All these you should know because many times clinically they ask questions on this. Okay. Now compulsions. C for compulsions. Most common compulsion is checking. जिसको पैथोलॉजिकल डाउट था वो बार बार जाके चेक कर रहा है, whether I bolted the door 10 times, 20 times, repeatedly they are checking. Okay, you should know the most common. Second most common also you should know is washing. Okay, जिसका contamination था, now they are also washing the hands. Then there can be symmetry. Okay, symmetry. Okay, abhi now the patient is doing everything in symmetry. So these are some important obsessions and compulsion. Is it clear to everyone? Now again, in the treatment again we have drugs like SSRIs. SSRIs are the first line drugs. Also there is a TCA, clomipramine. It is a TCA which we use, but again we prefer SSRIs because of less side effects. Okay, so pharmacotherapy again the treatment is SSRI. In psychotherapy again we use CBT, and one specific CBT we use is ERP. What is ERP? Exposure and response prevention. It is a type of CBT. देखो, if in the question you get both the option that for treatment of OCD which therapy will you use, which you will go for, CBT or ERP? देखो, ERP is a type of CBT, but you will go for more specific. Yes, ERP. ERP will be a better answer. Okay, treatment of choice sometimes they ask. So देखो, हमें पता है drug of choice, therapy of choice, treatment of choice. Can anybody tell me treatment of choice क्या है? It is combination drugs plus therapy. It is drugs plus therapy. Okay, so this is very important. Okay, देखो, तो obsessive compulsive and related disorders जो entity थी we had discussed, उसमें first was OCD. Another is body dysmorphic disorder. Body dysmorphic, देखो नाम से ही पता चल रहा है. Body dysmorphic disorder का मतलब क्या है? There is something abnormal, dysmorphic in the body. So body में कुछ patient is getting repeated thought that there is something dysmorphic in my body. So patient is preoccupied with some defect. Sir, I'm getting, I think my nose is large or my nose is small, my ears are large or ears are small. Okay, so this is body dysmorphic disorder. Next is hoarding disorder. Hoarding का मतलब क्या होता है? To keep on collecting. So patient keep on collecting things which are of very little or no value. Patient बाहर कुछ चीज़ें इकट्ठी करता है. So we had a patient जिसने 10 years से he has been collecting all the newspapers, all the magazines. This is hoarding disorder. Now next is hair pulling disorder. It is also known as trichotillomania. It is also known as trichotillomania. Okay, hair pulling disorder is also known as trichotillomania. Basically, patient is repetitively, there is repetitive hair pulling, okay, and excoriation is, there is skin picking, repeatedly he is picking the skin, so many times these patients go to a dermatologist because there will be alopecia or there will be some skin lesion, but ultimately they may be referred back to the psychiatrist. Okay, now these in ICD-11, there is a new term in ICD-11, body focused repetitive behavior disorder. Both of them are classified under this entity. Okay, this again you can remember, body focused repetitive behavior disorder. Many a times people who have trichotillomania, they may also eat the hair. Not normally it is not there, but sometimes they, that is known as trichophagia. Okay, and in the stomach again the mass of hair may be present, that is known as trichobezoar. So there was a very interesting question from this topic. A patient underwent, it is an FMG question, surgery and a mass of hair was found in the stomach. Which specialist should be consulted afterwards? So that means that patient was pulling the hair and he was eating, and that is now present as trichobezoar. So this is trichotillomania. You should consult a psychiatrist. Clear to everyone? Now there was also another image based question. Somebody was repeatedly hand washing, their image was shown, although no use of that image, but they would ask what is the diagnosis. OCD was the answer. Another interesting question was, a patient was eating each meals in equal parts. Okay, there was a question in your FMG exam, a patient was cutting each meal in equal pieces. What is the diagnosis? देखो पहला ऑप्शन उन्होंने दे दिया एनोरेक्सिया, एक ईटिंग डिसऑर्डर दे दिया, बट प्लीज रिमेंबर पर्सन इज डूइंग समथिंग वेरी सिमेट्रिकल. तो इसका आंसर क्या है? इट इज OCD. Very good, it is OCD. Is it clear to everyone? This is OCD. Is it clear to everyone? Okay. Now, next we are going to discuss, briefly somatic symptom and related disorders. देखो, ये वो these are those disorders in which symptoms appear physical. Symptoms, they appear physical, but there is no physical cause. There is no physical cause. Cause physical नहीं है. Okay, there is no physical cause. Okay. Okay, let us continue. Okay, there is no physical cause. Okay, so basically what happens is patient को कुछ symptoms हैं. Okay, but what will be given in the question? Patient का आपने examination किया, it is normal. आपने investigation की, it is normal. Symptoms physical है, patient को pain है, or there are other symptoms, but everything is coming out to be normal. And many a times there may be some stressor. एक stressor, it may or may not be present, may be given in the question. So this is telling you that you are dealing with somatic symptom and related disorders. Okay, so let us talk about this. First is conversion disorder. What is conversion disorder? Basically, a new name has been given in DSM, which is very, the name is telling you the problem. Functional neurological symptom disorder. Matlab patient has neurological symptoms which are functional in nature. That means there is no bodily cause. So patient can have sensory symptoms. Patient says that patient is not able to see. Patient complains that I am not able to see. Blindness. Patient is suddenly complaining of blindness or deafness. Okay, or hemianesthesia. Okay, patient is complaining of sensory symptoms. आप एग्जामिन करते हो, इन्वेस्टिगेट करते हो, सब कुछ नॉर्मल आता है, एंड देयर मे बी सम स्ट्रेसर. देन पेशेंट मे हैव सम मोटर सिम्टम्स लाइक पैरालिसिस. Patient says I am not able to move my body, or there is paraplegia. Okay, or sometimes patient may have seizure like activities. Okay, these are they are not true seizure, they are known as pseudo seizures. Okay, and sometimes patient may have both. Dekho, patient has neurological symptoms, but there is no, you cannot find any neurological cause. Okay, this is conversion disorder. We'll talk about. So hysteria basically is an older term. It's a larger term which include all these. Now you have given some specific name to these disorders. Okay, So this is conversion disorder. There is one interesting term in conversion disorder, that is la bella indifference. What is la bella indifference? देखो, the patient indifference, the name is telling you. देखो, suddenly patient has turned blind. Let us say a girl is sitting, her parents are fighting, and they say that we want a divorce. Mother comes and says, let us go, I am taking a separate divorce from your father. And the girl suddenly says, mother, where are you? I cannot see you. So so there is some stressor present, and she is sitting very comfortably. There is she is not worried about her serious symptom. This is la bella indifference, careless attitude towards the serious symptom. Okay, this is la bella indifference. Then next two disorders we can discuss them together, and let's try to understand the difference. Somatic symptom disorder, this was previously known as somatization. Previously this was known as somatization. Here basically patient is preoccupied with some bodily symptom. Patient says, sir, I am having pain, I am having this, I am that. Patient has numerous symptoms which don't have any cause. There is no physical cause, but he is just preoccupied with the symptom. That is somatic symptom disorder. While in hypochondriasis, the patient is preoccupied of having a serious illness. Patient says, sir, I think I am having pain, I think I am having brain tumor. Do some investigation. You do investigation, still the patient is worried. Or patient may not name the illness, just say, I think I am having some serious illness. This is hypochondriasis. यहाँ पे सिर्फ symptoms हैं. Here the patient is worried about some serious illness. Hypochondriasis is given a new name in DSM-5, very interesting and very right name, illness anxiety disorder. Illness anxiety disorder. Anxiety of having some serious illness. Name is telling you this is illness anxiety disorder. Okay, clear to everyone? Now let's come to the next and very important topic, substance use disorder. Substance use disorder. Okay, substance use disorder. Most important substance is alcohol. Alcohol is one of the favorite topics of your examiners. So alcohol withdrawal, person is, what is present in, what is there in beverage alcohol? Can anybody tell me? Alcohol में क्या content होता है? Beverage alcohol has ethanol. Okay. So patient yes. So alcohol, yes, 30 ml is yes, 1 peg, yes. So suppose patient is consuming alcohol and suddenly stops. So withdrawal symptoms basically occur when the patient stops or decrease the amount. Now these are again very important. This has been asked multiple times. So patient is consuming, let us say, large amount of alcohol and he stops taking alcohol. In the next 6 to 8 hours, he may develop tremors. This is again an FMG question. That two versions of the question were there, sir. The question was which is the most common or which is the earliest symptom. The answer is tremors. So it will be tremors. So initially tremors will develop. If this withdrawal state continues in the next 8 to 12 hours, patient may develop alcoholic hallucinosis. So patient will develop hallucinations. Here auditory hallucinations will be more than visual. So patient, as if patient is talking to someone, patient is hearing voices. Okay, then if this withdrawal state continues for the next 12 to 24 hours, patient may develop seizures. Okay, so these are known as withdrawal seizures. These are generalized tonic-clonic seizures. And if this withdrawal state continues, this is very important. This has been asked numerously in your exams. Patient may land up into delirium tremens. Can anybody tell me what will be the important symptom of delirium tremens? Patient is in a delirium state. There is impairment of consciousness. So patient they will give you in the question sensorium or confusion, or patient is having disorientation, okay, along with other symptoms. Okay, in delirium tremens, please remember in delirium, which is the more common hallucination? Visual hallucination will be more common than auditory. Very good. So again, this table is very important, so I want you to remember this very important table. Now next is, before coming to the treatment, there is something known as alcohol induced neurocognitive disorder. Alcohol induced neurocognitive disorder. So chronic use of alcohol can lead to some neurocognitive disorders. Again, many questions have been asked from this. So there are two important disorders, Wernicke's encephalopathy and Korsakoff syndrome. Wernicke's is basically acute, Korsakoff is chronic. It takes time. So, you can remember the symptoms of Wernicke's encephalopathy. It has global confusion. It has ophthalmoplegia, means there may be deviation of the eyes like this, patient is not able to move, and there is ataxia. Now, the question which was asked was, alcohol induced neurocognitive disorder, the cause is, what is the cause of these disorders? You should remember deficiency of vitamin B1 or thiamine deficiency. And how do we treat? We treat by giving thiamine. Okay. So, two questions were asked, one was on Wernicke's and one was this. Okay. Then Korsakoff, syndrome we have discussed, it has amnesia. It has amnesia and also confabulation. What is confabulation? Basically, patient tries to fill the memory gaps, okay, by false stories. So, patient does not remember what happened in the night, but he makes up a false story. This is confabulation, okay. This is confabulation, right. Now, then in the treatment, please remember, in the treatment, we have two stages. One is we do detoxification and then there is maintenance, okay. Detoxification basically means we treat the withdrawal symptoms. So, what is the drug of choice? Yes, Nani, anterograde was in Korsakoff, anterograde is more than retrograde amnesia, yes. Okay, what is the drug of choice? It is benzodiazepines. Benzodiazepines, this is again very important. So, we have various benzodiazepines like lorazepam, oxazepam, okay. We have diazepam, then chlordiazepoxide, okay. Now, please remember, this question has been multiple times asked. If suppose the liver is compromised, which can happen in liver, alcohol, patient consuming alcohol, there can be alcohol, liver disease, then you can use lorazepam or oxazepam. These are liver safe. These are liver safe. This is again very, very important. This question has been asked. Along with benzodiazepine, we can also add thiamine. This also has been asked. Okay, so we can also add thiamine. Okay, so this is how we treat the withdrawal state. This is how we treat the withdrawal state. Now, coming to the maintenance. Now, suppose you have treated the withdrawal state. Now, the patient says, sir, can I go home? So, you will say, of course, you can go home, but we want you to be in the abstinent phase. So, for this, we have two types of drugs. One is disulfiram. Which is also known as aversive therapy. This question was also asked, aversive therapy, okay, aversion therapy, it's an aversive therapy. What do we mean by this? Basically, disulfiram inhibits this enzyme. It inhibits aldehyde dehydrogenase, okay, disulfiram inhibits aldehyde dehydrogenase. So, what happens? Patient disulfiram le raha hai and patient, let us say, consumes alcohol. So, if he consumes alcohol, it will be metabolized to acetaldehyde. But acetaldehyde will not be further metabolized to acetic acid because this enzyme is inhibited. So, what will happen? There will be increase in acetaldehyde, which causes unpleasant symptoms. So, patient जब भी alcohol लेगा disulfiram के ऊपर, he will get unpleasant symptoms and he will feel that alcohol is causing these symptoms. So, he will become aversive to alcohol. Okay, so one is disulfiram. Again, this is important. Remember the mechanism of action. Then we have anti-craving agents. So basically patient says, I get craving for alcohol. Can you give me any anti-craving agent? So we have, yes, one is acamprosate. What is the mechanism of action of acamprosate? Same as mementin. Mementin का mechanism of action क्या था? It is NMDA antagonist. And naltrexone also can be used as an anti-craving agent. It is a mu opioid antagonist. Very good. So, please remember this again. These questions have been multiple times asked in your exams. Very, very important. Yes, there are other also. These two are FDA approved anti-craving agents. Is it clear to everyone? Then next is opioid. Okay, next is opioid. So, opioid basically are derived from poppy plant, Papaver somniferum. Most common abused opioid is heroin. What is heroin? It is diacetyl morphine. What is heroin? It is diacetyl morphine. Okay. Now in the opioid, again please remember the opioid withdrawal symptoms. Again these are important. Opioid withdrawal symptoms, these are important. One is, again, I've tried to categorize them so that it becomes very easy for you to remember. Patient will complain of pain. Patient will complain of pain, like there is muscle pain, bone pain. So patient says, if I stop consuming opioid, I develop muscle pain, bone pain, abdominal, pain is there. There is leakage of body outlets. So there is complaint, patient will complain of diarrhea. Okay. Patient will complain of rhinorrhea, running nose. Patient will complain of lacrimation, tears may come, or it will also complain of sweating. So patient says, whenever I stop consuming these substances, I develop these symptoms. Patient will complain of excessive yawning. If you look in the eyes of the patient, patient says, meri aankhon mein dekho, what will you find? Pupillary dilatation or mydriasis. There will be mydriasis. Okay, and piloerection or goose flesh may also be seen, goose flesh. Okay, so these are important withdrawal symptoms, very, very important. Again, when we treat opioid, we can again treat in two phases, detoxification and maintenance. Okay, so in two phases we can treat, one is detoxification and one is maintenance. Okay. Now, so in the detoxification, again, patient was consuming impure form, we will give him pure opioids like methadone. Okay, methadone. So, humne methadone diya, that is a pure, it's a mu agonist. Or we can also give buprenorphine. Please remember, morphine, it rhymes. So, it is buprenorphine. It is a partial mu agonist. It is a partial mu agonist. Then symptomatic also, sometimes patient says, don't give me any opioid. Then you can symptomatically also manage by giving clonidine. Okay, clonidine is a alpha agonist. It decreases, so sympathetic activity is high, it decreases the sympathetic activity. Okay, so this is how we treat the withdrawals. This is how we treat the withdrawals. Now in the maintenance, again, patient is taking, was taking opioid. So now we want that he does not take opioid. Okay. Okay, so how we can treat in the maintenance? We can give opioid substitution therapy, OST. So in OST we can again use methadone and buprenorphine, okay, and sometimes we can also use naltrexone. Naltrexone is a mu antagonist, opioid antagonist. Okay, so we can use antagonist. Okay, so again this is important. Is it clear to everyone? Right. Now let's talk about tobacco. Okay, now tobacco, basically what is the psychoactive agent in tobacco? It is nicotine. Okay, so patient consumes tobacco. Again, important is the treatment. So in the treatment of tobacco dependence, we can use nicotine replacement therapy. Therapies like there are gums, lozenges, very good. Okay, patches are there, and we can also give anti-craving agents. Again, these are very important. Recently many questions have been asked. So first important anti-craving agent is varenicline. What is the mechanism of action of varenicline? Again, this is important. It is a partial agonist. At alpha 4 beta 2. Please remember, alpha 4 beta 2 and nicotinic acetylcholine receptor. So this is again important. And okay, nicotine, varenicline is there. Okay, and please remember, it is out of these, it is the most efficacious. So if you are asked out of these which one drug you will choose, it is varenicline. Second is, we can also use bupropion. We know it is a antidepressant, NDRI. Okay, norepinephrine dopamine reuptake inhibitor. So a question was asked in your exam, antidepressant, it's an antidepressant used for smoking cessation, bupropion. Out of the three, you will choose varenicline as the, if you have to choose one, as a better answer. Is it clear to everyone? These are all important questions. Look, if you you know, when we are revising, I want you to discuss all these important topics so that, you know, it becomes very, you know, this big session becomes very, very fruitful to all of you. Is it clear? I hope, is it clear? I hope it is going fine. Right. Next is child psychiatry. Next is child psychiatry. Okay. Now, few important topics in child psychiatry. First is ADHD. So, what happens in ADHD? So, as the name suggests, there is attention deficit is there and hyperactivity is there. नाम से पता चल रहा है. So, there is inattention. There is inattention. So, basically, when the child has inattention, what kind of symptoms will be there? He will fail to give attention to details. Okay. So, parents will complain that he makes careless mistakes. He gets easily distracted. एक चीज़ को बहुत देर तक he is not able to focus. Okay. Then child may also have hyperactivity or impulsivity. Okay. So, in hyperactivity, they will complain he is very fidgety. Even if he is sitting, he is doing like this, very, very fidgety. He is always on the go. You know, harbar he just keeps on running. He leaves his seat where seating may be, you know, necessary. Like in class, teacher says, he gets up and starts moving. Or he is very impulsive. He can't wait for his turn. So, these are the two important symptoms which we see in ADHD. Okay, ADHD. So, this is again important. ADHD is more common in boys than girls. Okay, much more common in boys than girls. Okay, and what is the treatment of ADHD? What is the drug of choice? So, basically pharmacotherapy is the treatment of choice. The drug is methylphenidate. Drug is methylphenidate. Okay, again it is important. Okay, so this is ADHD. Next is autism spectrum disorder. Okay, next is autism spectrum disorder. These are also known as, very good Vimal, yes, methylphenidate. Autism spectrum disorder, these were earlier known as pervasive developmental disorder. Okay, the earlier name was pervasive developmental disorder. Again, just like ADHD, they also have two symptoms. First is deficit in social communication. They have problems in social communication. Okay, their social communication is very poor. They have awkward social behavior and they have some repetitive pattern of behavior. There are certain behaviors which they keep on repeating. Have you seen, you know, anyone seen the Big Bang Theory? You know, Sheldon Cooper, if you've seen that character, okay, again, you know, he's having poor social communication and very repetitive patterns of behavior. Okay, okay, so this is autism spectrum disorder. This is autism spectrum disorder. Now, basically what DSM-5 has done is, or ICD-11, so they have grouped all the disorders which are similar into this one category. So, like autism, Rett syndrome, Heller syndrome, Asperger's, these are the disorders which are seen under this category of autism spectrum disorder. Okay. Now, again in child psychiatry, most of the disorders are more common in boys, okay, than girls. But one important disorder I want you to remember is Rett syndrome. Okay, Rett syndrome is again important. Rett syndrome is more common in, can anybody tell me it is more common in boys or girls? It is more common in females than males, much more common in females. Again, this is a previously asked question, important. Okay, very good. Yes, Vish, yes, Vikash. Now, what are the interesting points about Rett syndrome is, again, it will have the common characteristic of social communication deficit and repetitive behaviors. Okay. Now, in the first 5 months, very good Jitu, yes, there is absolutely normal development. There will be no abnormality. Pehle 5 months will be normal. Problem starts in the next 6 months to 2 months. Okay. So, what kind of problem? There will be some stereotypic, some odd movements known as hand wringing, like look like this. These are basically midline repetitive movements. Some repetitive movements in the midline will be there. Very important, especially for your exams, microcephaly. Dekho, microcephaly is not present at birth, but it is present after 5 months of development. So, microcephaly, then loss of speech, muscle coordination, these may also be present. So, this is Rett syndrome. This is Rett syndrome. Yes, MECP1G, very good. So, this is Rett syndrome. Okay. Now, then there is specific learning disorder, SLD. Again, a question was asked on this. So, in SLD, basically what is happening is there is poor academic skills. If you seen this movie, the child is otherwise normal, just he is having problem in academics. So this was a question which was asked, a child has poor marks in mathematics, rest everything is normal. What was the diagnosis? It is SLD. So there can be problems in reading, which is known as dyslexia. So child is not able to read. Then writing, child has difficulty in writing, poor handwriting. Problems in mathematics may be there, and it can be mixed. Again, this is very, very important. Again, these are small topics which have been asked recently, so you should know. Lastly, in this is mental retardation. Mental retardation is also known as intellectual disability. Mental retardation is also known as intellectual disability, new name. So in this you should know what is IQ. What is IQ? IQ is basically, IQ is calculated by mental age. You should know the formula. IQ is mental age upon chronological age into 100. So basically mental age is, we calculate the mental age of the child by performing some test. Chronological age basically means age calculated by the date of birth. Okay. So mental age upon chronological age into 100. One important point in this is chronological age should not be more than 15 in the denominator. So you should know. Yes, very good. Yes, Sanjay, very good. Okay, so this is again important. You should know this. Now, coming to this, again mental retardation may be classified into mild, moderate, severe and profound. Again, these values you should know. What is mental retardation? Basically, we say when the IQ is less than 70. This question again was asked recently in your exam, so you should know these values. Can anybody tell me what is mild MR? Anyone? What is mild MR? What will be the IQ levels? Anyone? What will be mild? It is when the IQ, so it should be less than 70, 69 to 50. Okay. What is moderate mental retardation? When it is 49 to between 30, between 49 to 30. Severe is when it is, severe is basic, so it is 35. Severe is 34 to 20 and profound is less than 20. So again, very good. Please remember this has been asked. Most common genetic cause of mental retardation. Can anybody tell me? It is 35. Okay. This is these values, please remember. Okay, please remember these values. Okay. Most common genetic cause of mental retardation is Down syndrome. Very good. Down syndrome. And second is Fragile X syndrome. Fragile X syndrome. Very good. Fragile X syndrome. Very good. Very good. Yes, Abdul. Very good. Vikas, Skrope, Sanjay. Very good. All are correct. Very good. Now let's talk about, these are very small topics. Let me touch upon some important points of these topics. Okay, so sleep disorders. Now basically sleep is divided into two, NREM sleep and REM. Let me give you some tricks to remember. These will be very helpful. So there is NREM, non-rapid eye movement sleep, and REM sleep. Dekho. Generally what we see is body movements are present in NREM while they are absent in REM. REM is a state as if the body is under paralysis. So कोई भी sleep disorder in which it has movements, tell me वो NREM होगा या REM होगा? अगर किसी sleep disorder में movements, so it will be NREM or REM? It will be NREM, like somnambulism, sleep walking. Okay, somniloquy, sleep talking. ये सारे NREM disorders. Okay. Also please remember dreams. If you see, we see dreams in both the stages. But which stage dreams do we remember? Can anybody tell me? So you can remember like this. Dreams of NREM are not remembered. Please remember like this. So you will not forget. Are not remembered. While dreams of REM are remembered. Okay. Are remembered. Okay. Right. Now, one important sleep disorder you can remember is narcolepsy. Narcolepsy, it's a REM disorder, REM sleep disorder, the REM sleep disorder. So what are the important symptoms in narcolepsy? One is there are sleep attacks. So patient has excessive sleepiness. So patient has episodes that he wants to sleep. Excessive sleepiness is there. Okay. Then second is, if you remember, one was catalepsy, जो हमने कैटाटोनिया में डिस्कस किया, that this is cataplexy. तो नार्कोलेप्सी में प्लीज रिमेंबर कैटालेप्सी नहीं मिलता, कैटाप्लेक्सी मिलता है. व्हाट इज बेसिकली कैटाप्लेक्सी? देयर इज लॉस ऑफ मसल टोन. So patient is sitting and suddenly patient has fallen. Patient is standing, suddenly fall. So there is loss of muscle tone. Patient may even fall. Okay. Then next is sleep paralysis. Next is sleep paralysis. Basically sleep paralysis. Aneroid is basically, Jitu, it's a dream-like state, which it's a type of impaired consciousness. And aneroid state is a dream-like state. It is a type of impaired consciousness. Now, sleep paralysis, basically patient wakes up from sleep, but he finds that he is not able to move the body, not able to move his body. That is sleep paralysis. So, he is in a state of paralysis after waking up. So, this is again the third symptom. And the lastly, it is, these are hallucinations which occur at some specific time. So, hypnagogic you can remember like this, and hypnopompic. So, you can remember hypnagogic है hallucination which occurs when the patient is going to sleep. When the patient is going to sleep. So, जब patient सो रहा है, he is getting some hallucinations, hypnagogic, and hypnopompic is when he is when he is coming out of sleep. When he is coming out of sleep. Okay. So, this is hypnopompic. Okay. So, you can remember it like this. Is it clear? Right. So, again narcolepsy, what is the cause of narcolepsy? Basically the cause is deficiency of hypo. So, what is the cause of narcolepsy? It is not working, just give me a second. Yes. So, hypocretin, yes, correct. Hypocretin. Okay. So, it's basically a neurotransmitter required for wakefulness, alertness. Treatment is, we give modafinil. We give modafinil. It is a stimulant. Okay. So, patient is having excessive sleepiness. So, we give modafinil. Okay. So, we give modafinil. It is a alpha-1 agonist. And also we can give forced naps. We tell the patient to take forced naps in between. Okay. So, this is modafinil. Okay. Now, in sexual disorders, let me talk about some important sexual disorders. Two important disorders I want to discuss. One is erectile disorder. Okay. So, again, erectile disorder is basically there is problem in erection. Okay. So, patient is not able to have proper penile erection. Okay. So, it has cause, it can have psychogenic cause, and it can have organic. Organic means there is some problem in the body, like the blood flow is not proper, there is problem in the nerves. Okay. Psychogenic we say is the most common. Now, when we talk about again in sexual disorder, lot of questions have been asked on the treatment. First in the treatment is the drugs. We use drugs like phosphodiesterase 5 inhibitors, PDE5 inhibitors. Basically, they increase the blood flow. Okay, like drugs like sildenafil, tadalafil, vardenafil, all these pills again we use. Now, very important are the therapies. Please remember the therapy. So, psychotherapy, you should remember, generally whenever we treat sexual disorder, we use dual therapy. Okay. Dual therapy means we just not treat the patient, we treat the couple, in which one important therapy is sensate focus exercises. This is again very, very important. Please remember these names. A lot of questions have been asked on this topic. Please remember this. Okay. Second important disorder is premature ejaculation. As the name suggests, premature ejaculation means ejaculation is occurring early. So, it may occur before penetration or just immediately after penetration. Okay. DSM-5 in fact says if it occurs in less than 1 minute, then it is premature ejaculation. Dekho, this is again a very important question which has been multiple times asked. Therapy for premature ejaculation. One is squeeze technique and the other is stop start technique. These are all important therapies. Please remember these therapies. These are very, very important. Okay. Then in drugs, I told you SSRIs have some sexual side effect. So, one of the side effect of SSRIs is that they delay ejaculation. This is what is needed in these patients, isn't it? So we use the side effect of SSRIs for the treatment of PME. Is it clear to everyone? Lastly, what is nymphomania? What is nymphomania? Again, these questions have been asked in your exams. Nymphomania is excessive sexual desire in females. In females. Okay. Yes, even those drugs, yes, we can use. Yes, Gongyu. And satyriasis, what is satyriasis? Sexual desire, excessive sexual desire in males. Okay. So this is again important. Okay. So these are again very, very important questions which are asked. Now, eating disorders. Okay. Now, there are two important eating disorders which we are going to discuss. One is anorexia nervosa. First is anorexia nervosa. Now, eating disorders, again, all these eating disorders are much more common in females than males. Okay. What are the characteristics of anorexia nervosa? There is disturbance of body image. Please remember, there is a disturbed body image. What do we mean by this? Now, suppose this is a normal, suppose this is the normal body structure. Let me draw it. Suppose this is the normal body structure and this is the body structure of an obese person and this is the body structure of the patient. So, patient perceive herself to be fat. Patient perceives that she is fat. Although the patient may be like this, but patient perceive that I am fat. So, there is a disturbance of body image, first symptom. Second is there is fear of fatness. Patient fear, oh my god, I will become fat. Oh my god, I will gain weight. So, there is excessive fear of fatness and there is restriction of energy intake, because of which the patient does not eat properly. So, there is a decrease in the weight. The BMI becomes very low. It becomes less than 18.5 kg per meter square. Okay. Okay. So, yes, we will talk about that, Sanjay. Yes. So, in anorexia, we know that the BMI is low. There was another fourth symptom which has now been removed. It was earlier there, that was amenorrhea. That is cessation of menses. It was earlier a symptom of core criteria, but now it has been removed from this. Okay. It may be present in the patient. So, these patients will have signs and symptoms of starvation. Okay, in starvation because they are not eating properly. Anorexia nervosa again can be of two subtypes. One is restricting type. It is the most common. So, basically patient is not eating because of the above symptoms, and even they can have binge eating and purging type. Binge eating means eating large amount of food in less time. So, patient may eat 8 chapatis, 10 chapatis in few minutes, and then they may do purging like self-induced vomiting. Okay. So, please see, binge eating, purging and bulimia may be hoga, but anorexia nervosa may, if it is there, before that these symptoms should be present, which is not there in bulimia nervosa. Is it clear to everyone? Is it clear? Now, this is very important. These patients may require hospitalization. These patients may require hospitalization because of lots of complications like dehydration, electrolyte imbalance. Again, then there may be decrease in the weight by height. Okay. So, because of these symptoms, they may require hospitalization. Okay. And if we treat it with drug, with CBT, and we can use drugs like SSRIs. Okay. With SSRI. So, we will just take another 10 minutes and then we will finish. Okay. Now, the next is bulimia nervosa. Bulimia nervosa. Again, bulimia nervosa is more common in females than males, and there are episodes of binge eating, so which is followed by compensatory behaviors like purging, self-induced vomiting. Sometimes they may use drugs like laxatives, diuretics, or they may also do some excessive exercises. Okay. BMI in these patients may be normal or it may be increased. Okay. It may be normal or it may be increased. Okay. This is bulimia nervosa. Now, in bulimia nervosa, there may be complications like there may be dental caries. Again, important, because they are repeatedly self-induced vomiting. So, gastric acidic content is coming in the mouth. So, there may be dental caries. They may have parotitis. Russell sign may be seen. If you see their knuckles, there is callus on the knuckles. the knuckles of their hands may be callous, they may become very hard because of repeated injuries. Okay. Now one important finding is, can anybody tell me in these patients will there be alkalosis or acidosis? Can anybody tell me will there be alkalosis or acidosis? There will be alkalosis because the acidic content is going out. Okay, so there is hypocalemic, hypochloremic, very good. Alkalosis again important, very good, very good. Again treatment we can do CBT and we can use SSRIs. Again these are more easier to treat, and please remember bulimia nervosa is more common than anorexia, nervosa. Very good Vikas, Vish, Vimal, Sanjay, very good. Dr. Sunshine, very good. Now let's talk about personality disorders. Now personality disorders, these are the last disorders, okay, last group of disorders which we are discussing. Dekho, personality disorders are what? These are basically, personality is our behavior, day-to-day behavior, by which we deal with day-to-day situation. So personality disorder is when the behavior becomes abnormal. The behavior becomes abnormal. Okay. So the behavior becomes abnormal. So it deviates from the normal standard. Okay. Now please understand, whenever you see personality disorder patient, generally they will have an onset at around this 16, 17, 18 years of age, and the symptoms will remain stable through time. So किसी को भी जब personality disorder होगा, this is how you will get the history, that these symptoms have been present for a long time. Such pattern of behavior is present for a long time. So basically we have divided the personality disorders into 3 clusters. Just remember, at least you should know the names. There is cluster A, B and C. So I have given the clusters, all the disorders under this. Cluster A are they have a common characteristics, they are very weird. Cluster B, they appear very wild, and cluster C, they appear to be very worried. Okay, so I have given, so you should at least remember these names. Few points about some of the important ones. Antisocial is when the patient is having very behavior which is against the society. So patient having behavior against the society, so he violates rights of others, starts getting into fights, beats anyone. Okay, they con, they theft, they are involved in gambling, or they are involved in gang activities. So they are antisocial. Okay, so any 90s movie, if you see the villain of the 90s movie, you will find a lot of antisocial personality traits in them. Okay, borderline I will discuss in detail. Then obsessive compulsive personality disorders, these are the people who abide by the rules and regulations. They abide by the rules and the regulations. They want to do everything with perfection. Can anybody tell me any person from social life you think can have this obsessive compulsive personality disorder? Please remember, they don't have obsessions or compulsion. The name is obsessive compulsive. Agar obsessions compulsions honge to wo OCD ho jayega. This is OCPD. Very good, Jeeti. Yes. Now borderline personality disorder, I want you to remember, this is very, very important. This is very, very important for your exam. Okay, this is, you can expect a question. Please remember, expect a question from this. Very, very important. So they have basically unstable relationships. These are more common, you can remember, more common in females than males. So they have unstable relationships. So suppose you get a case, a married, newly married female comes in the emergency and she reports that she had unstable relationships have been there in the past. She has she does things out of impulse. Out of impulse she may do things which may harm her. Then there is recurrent suicidal behavior or threat. You may see the risk, you may find a lot of intention wounds. Okay, the attempt may be not very severe, but there will be recurrent suicidal behavior or threat. Mood will be unstable. Mood will be unstable. Again, you are sitting and suddenly they may burst into anger. So these again are important symptoms which you find in borderline personality disorder. Classical question, a lady comes to the emergency with suicide attempt. She reports of unstable relationship, mood instability, impulsive acts have been there in the past. Diagnosis: borderline personality disorder. In the treatment, generally personality disorders, when we treat with therapy. One important therapy for this is dialectical behavior therapy, or DBT. This is again very, very important. Please remember this. Okay, please remember this. This is again I am highlighting, you can get a question from this. Very, very important. Now lastly, few words about Freud. Freud has done a lot of work in psychology and psychiatry. He is also known as father of psychoanalysis, the famous picture of Sigmund Freud. Psycho means the mind, analysis means analyzing the mind. So he tried to analyze the mind and gave so many theories. Now nowadays, questions don't come from those theories, but still I'll briefly tell you some of them. Okay, he gave the concept of free association. Free association means he makes the patient, he would make the patient lie down on a couch and tell him whatever comes to his mind, just keep on speaking. This is free association. Okay, now these two important terms are important here. This is important. These two terms are very important. One is transference. One is transference. What is transference? So basically, in psychiatry, when we are talking to patient, we talk for so much time. The patient discuss so many important things which the patient might not have discussed with anyone else. So there is there are certain phenomena which may happen. One is transference. Transference is feelings of the patient towards the therapist or towards the doctor. Now these feelings can be conscious or unconscious. That means patient either is aware or is not aware of these feelings. These can be good feelings or can be bad feelings. Okay, positive or negative. Patient may say, "Sir, you are just like my stepfather. Just like my father, who was very warm, very good." So these are positive. And one patient may say to another therapist, "So you are just like my stepfather. You are very mean." So ये positive भी हो सकती है, negative. Next is counter transference. Counter transference अब opposite है. ये feelings of therapist हैं towards the patient. देखो, अगर transference develop होती है, that may be used in the therapy. Okay, but counter transference, if it happens, it is not good. Maybe you can refer the patient to some other therapist. Okay, so please remember these terms, transference and counter transference. This is again very important. Now he gave many many models. These are again hypothetical theories. One was topographical model of mind. He said mind is divided into three. One is conscious. One is conscious means that you are aware of the content. Whatever is there in the conscious mind, you know that. Your feelings, your memories, you know about it. Okay, you are aware of it. Pre-conscious, he says, at present you are not aware, but you can be made aware of. Okay, for example, if I ask you, what were you doing at this very moment 1 year back? So you will say, "Sir, I don't know." But suppose we take you into therapy and we go back every day, maybe you will be able to remember. So this is in the pre-conscious. Unconscious is which is not in the awareness, which is not in your awareness. The content of this is not in the awareness. This is one model. Another model which he gave was structural model of mind. Okay, he again classified mind into id, ego and superego. Okay, id, he used to say, is basically the animal instincts, okay, which requires immediate gratification. Okay, so ये part of the mind says that I want immediate gratification, अभी करना है. While superego is basically the moral compass. It says you should do whatever is society tells you. You should follow the norms, the rules, the regulations. So एक mind is saying to do immediately what I want. One mind is saying no, follow the rules. So there is a fiction. So then what comes to the rescue is ego. Ego is the balancer. It is known as the, so it is basically the executive organ. Executive organ of the mind or the psyche. Okay, it tries to balance out. I will give you a very simple example. Suppose there is a student. So ego is, so it is saying, so you should play. What are you doing? Let's go and play. Let's watch a movie. Superego is saying, no, no, what are you doing? There are exams, you should study. So there is a fiction. So now ego will come to the rescue. Ego will say, okay, let's study for 2 hours and then let's go and play. So this is how this structure model of mind works. Okay, so again this is a model given by Freud. So Freud said that ego uses certain techniques. Ego, not the attitude ego. Ego is a part of the mind. Okay, so ego uses certain techniques to balance out this fiction, which is known as defense mechanism. So again, please remember the questions. Recently we are not getting much question on defense mechanism. Still, I'll tell you some of them. Just read them, but again just read them. Defense mechanisms. So one is, there are many defense mechanisms. Don't go into the details. Just read a few which I am explaining. One is projection. Projection is basically, so patient attributes his own desires on someone else. So for example, patient is having an affair, extramarital affair, but patient is convinced that my wife is having an affair. So this is projection. Apni feelings he is projecting to someone else. Okay. Then next is acting out. So basically acting out is the unconscious impulse is enacted in behavior, but real emotion is concealed. Basically defense mechanism is trying to decrease the anxiety. Defense mechanisms are being used by the mind to decrease the anxiety. So acting out is patient is is enacting behavior to decrease his impulses, but real emotion is concealed. For example, you are walking in the dark, आप एक dark street में walk कर रहे हो and you start whistling. Now you are afraid, so you are starting whistling. So you are enacted in the behavior, but you are not showing the real emotion. This is acting out. Then displacement, very interesting. It is basically shifting of impulses to another object. So the husband was scolded by the boss. Husband comes and fights with the wife. The wife gets angry. She then shouts at the son. The son becomes angry and he shouts on the pet. So there is a displacement of the anger. Okay, so these are some important some of the few defense mechanisms. There are many more. Okay, now lastly I just want to discuss this act. So the last 2 slides of the day, this is again important. Mental Health Care Act 2017, MHCA 2017. Now basically it's a new act related with the mental health. You should know some of the important terms. First is advance directive. So advance directive means suppose 10 years later someone develops someone might develop some psychiatric illness in which the person may not be in the right capacity to take decisions. So advance directive says that you can write the way you wish to be treated or not to be treated for your mental illness. Suppose at that time you are not in the right capacity to take the decision, तब आप उस state of mind में नहीं हो कि आप decision ले सकते हो. Then you can in advance. So this is advance. In advance I am giving a directive. Next is nominated representative. So basically you can also nominate a representative. Suppose someone 10 years later is not in the right capacity to take decisions, treatment related decisions. So he can nominate someone, that I nominate my friend, I nominate my wife, I nominate my son to take those decisions for me. So you should remember these terms again from the name itself. You should remember. Now there are certain procedures which have been inhibited, which have been prohibited in this act. Direct ECT, as I told you, direct ECT is no longer permitted. You can give modified ECT. ECT in minors also it is prohibited, but you can still do that if you take permission from the board. So there are basically board in every district, every state, you can take their permission. Again, ban of psychosurgery. There are certain surgeries performed for certain disorders like OCD. OCD is one disorder for which psychosurgeries are performed. Again that is banned, but again you can do after taking permission. Okay. One important point is decriminalization of suicide. This is very important. Earlier if someone attempts suicide and he survives, he would IPC, he would be punished under IPC 309. But now they say now we will not punish him. So they have decriminalized the suicide. This is again very important step forward. And lastly, admission, if someone is taking a voluntary or an involuntary admission in a mental health establishment, so the maximum stay is 30 days. It can be increased after taking permission or after informing the review board. Okay, so these are important topics, very good. So these are lucid interval is in between the patient becomes all well. Okay, shared psychosis is basically suppose someone has developed some some psychotic disorder and maybe someone very close to him also may develop a similar disorder. So two people having the same disorder, that is shared psychosis. Okay, so again as I always say, keep smiling. I understand there are this is basically it depends on your attitude. Okay, so basically you can say, sir, we have only 35 days, or you can say, sir, I have 35 days. So please take it in a positive way, keep working ahead, keep smiling, always smile few times a day. It will relieve the anxiety, very important, and every day is a new day. Keep moving forward, keep moving forward. This is my message to all of you. I'm sure you'll do well. Please remember, all of you can succeed in this exam. You have to just touch the cutoff line, so all of you can succeed, and I'm sure you'll do well. So again, thank you everyone, thank you for your patient listening. This is very again, all the very best. Thank you guys, thank you so much. Thank you. Thank you so much. Good night.
Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update